Okay, so I think we can start now. أول شيء بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته جميعا. Welcome to a new lecture from the Pediatric GI Academy. So this lecture is from the emergency series in Pediatric GI Emergencies. Every fellow must master. So this topic will be a little bit different from other lectures because it contains a lot of emergencies. So we're going to go through clinical tips, important things you need to know as a fellow. I'm sure most of the fellows, they know these things, but these only to highlight an important things. Also, it will be helpful in your OSCE exam in the MCQs. Even I made some slides to be ready-made for OSCE exam. And inshallah, I'm going to distribute the presentation. And if my colleagues also agreed, they will distribute their presentation. I'm very glad that I will be here with Dr. Ghaidaa Dahlwi. She's a pediatric gastroenterologist and IBD specialist, and Dr. Mohammed Ayoub, who is a pediatric gastroenterologist and hepatologist. So before we start, I just would like to just give you overview about Pediatric GI Academy. The aim of this academy actually is just to spread the knowledge without any fees. Alhamdulillah, in the last 2 years, we made a lot of presentations. We have now YouTube channel, we have Twitter or X account, and we have WhatsApp group. Currently, the members of the academy, Mohammed Ayoub, Dr. Ghaidaa Dahlwi, and Dr. Saleh Al-Qahtani. And these actually, they were very helpful in this actually academy in terms of creating the structures, creating lectures for the upcoming, inshallah, months. And here also I would like to say, if you are interested to join our academy, please reach to me. This is the WhatsApp group. The aim of this WhatsApp group is just actually to have updates on the academy lectures, uploads on YouTube, and etc. Inshallah, in the next few months, we are going to have the Pediatric GI Fellowship Board Review Boot Camp. We did the first version, it was excellent, and we are planning to do the second version, inshallah, in the next few months. Also, we are going to do a pediatric gastroenterology review books. It will be a very good addition for fellows or anyone who's interested in GI in terms of exam preparations and clinical tips that you need during your clinical practice. And also, if you are interested to join us in this review book, please join me. Okay. So now we'll start with our lecture. So as a fellow, so I will go inshallah quick, and inshallah Dr. Mohammed Ayoub will count my time. So as a fellow, if you take my phone, you will see a lot of pictures like this. Every time ER or fellow, they will send me pictures at night about foreign body. So this is one of the important things that you have to master during the fellowships. So let us start to know, what do you need to know about foreign body ingestion in the children? First of all, actually, you have to have a good decision. You have to be a decision maker in these scenarios, because in few minutes you have to decide, admit, discharge, give him appointment, do another X-ray. So you have to be very good in decision making. But you cannot do this if you don't have a good clinical knowledge or good endoscopy skills, and you don't know which cases you don't have to miss. And you have also to make sure that you have other supportive members like ENT or surgery, and you have to know that this patient might have a complication, this patient might have not. So it's not only removing a foreign body, but knowing this, you have to know when to intervene, when to do endoscopy, how urgent to do, which tool do you use. You have to be familiar with the tools that you are going to use in foreign body extraction, when to involve other colleagues, and when do you think about complication before doing the procedure, and this is very important. So after they call you, you need to know some informations. What was the foreign body that was swallowed? When it was swallowed? What is the size and the shape based on the X-ray? Does the patient has other comorbidities? These are a standard question. I'm sure you are doing this automatically, but you have to make sure of all this information. After that, خلاص, you know this is a bottom battery into the esophagus. It was ingested probably 3 or 2 hours ago. Patient is previously healthy, taking some symptoms. Does he have any GI symptoms? Because this is very important, for example, in food impaction. If you have a child who has a food impaction, who has drooling of saliva, this is most likely a complete obstruction that need to be removed. But if he has a food impaction, but he can swallow his saliva, you are not in urgent to do the scope. Plus the GI symptoms, plus the respiratory. Here, respiratory is a very, very important to know about because it tells you that this patient might have a complication. So you have to anticipate this before doing the procedure. So as I said, it's not only a procedure, you have to anticipate complication. So look for red flags. Red flags, if patient has a foreign body and he's distressed, has severe chest pain, fever, upper GI bleeding, this is really not good. And if you suspect these foreign body, bottom battery, multiple magnet, or sharp object. Now you took the history that I mentioned. Now you need to do focus exam. The aim of the focus exam actually is to look for complications. Vital is stable. He has signs of complete obstruction. Does he have a signs of perforation? Either esophageal perforation or abdominal perforation, or he has some respiratory issue. So by this, you are knowing your patient and you think that this is unlikely, probably has a complication. I might wait or I might go for procedure. Let's go with the first case. This is a 1-year-old. He has history of decreased oral intake, persistent vomiting and fever. So these are all red flags. But no one mentioned here about foreign body. He was seen in multiple clinics because of viral upper respiratory tract infection. And now he started to have a stridor, noisy breathing. He refused to eat. No one talked about foreign body because he's a 1-year-old. So we are talking about unwitnessed foreign body. So I have to stress in this point 100 times for all fellows, and I remind myself, if you have a child who comes to you with a GI symptoms, means vomiting, without any other explanation, especially under the age of 2 years, please do X-ray. If you do 100 X-ray and you pick one foreign body, I think you get a credit. So here, no one, I'm sure that a lot of hospitals, they receive some cases, missed foreign body. Why it is missed? Because no one thought about it. But you, as a gastroenterologist, you have to think about it because this is bottom battery. Another patient, a 2 years old, in the risk group who has previously healthy, presented with upper GI bleeding with other symptoms. The second clue, any child who is under 3 years of age who has unwitnessed foreign body and he presented with upper GI bleeding, now even in the guideline they said please do chest X-ray, because when you do X-ray you will find a foreign body. Okay, so now the first important tip, think about unwitnessed foreign body ingestions. If a child has a GI symptoms or upper GI bleeding or vomiting or drooling, and you thought about there is nothing can explain, patient has no fever, no diarrhea, no runny nose, no other one in the family has any viral illness, please do X-ray. So these are the clues: sudden vomiting, drooling, respiratory symptoms. Think about esophageal foreign body until proven otherwise. Now let us go to the case number 2. 11-month-old has a drooling. He refused to eat. Mother is worried that he swallowed something. Now the mother is telling you that he swallowed something. So what you will do next? You will do X-ray. So you did X-ray. You said, Mom, everything is fine. You discharge her, you give her instruction, but mother came again because he still have persistent vomiting. But because there is a gastroenterologist, he was in the ER and he saw the X-ray and the mother what she said. And he said, this is not an enough X-ray. So please do appropriate X-ray. So for foreign body, it's not enough to order only chest X-ray. You have to do neck, chest, abdomen X-ray as a combo. You cannot say only chest X-ray. Please do it 3 times. You said radiation, yes, but you pick complications sometimes. You pick missed foreign body. So this is the tip number 2, order appropriate imaging. Location, type, because you need to know the location, type, and complication. Neck, chest, and abdomen is important. Make sure it is 2 views also. CT sometimes we consider, but we will talk about it later. Now we do 2-view X-ray, as you know, because you differentiate, is it in the trachea or in the esophagus? Not only this, because even in the bottom pattery, you know the issues in bottom pattery is from the negative pool of the bottom pattery. So if the negative pool is directed posteriorly, so patient might have complication in his spine. If it is the negative pool directed anteriorly, patient might have tracheoesophageal fistula or aortoesophageal fistula. So it will help you. Another thing that you have to know is that 2 riyals that we have now with the double ring. We know that the double ring actually, it tell you that this is a bottom pattery. But now with this 2 riyal is a little bit misleading, so don't be misled and don't assume this is 2 riyals. So if you have any doubt, please proceed as a bottom pattery. Don't say, no, this is the new 2 riyals. So by the end, you will talk to your consultant or talk to yourself that this patient, his age is this, he's previously healthy, he ingested this 2 days ago, for example, he's symptomatic or asymptomatic, physical exam is okay, hemodynamically stable, and most likely has no complication from the clinical assessment, and this is the X-ray. This is the full meal to digest. You don't have anything to do other than this, because based on this, you will assign yourself either I do emergent endoscopy, which is less than 2 hours, or urgent, which is within 24 hours, or I can book it next day or after 2 days. So let us come here to this case. So this is a 2 years old. He's previously healthy. He ingested this foreign body, which looked like a bottom pattery. 4 hours ago, he's asymptomatic. His last meal 2 hours ago. He's hemodynamically stable. And now in the ER, they let him stay in the triage, and this is based on a true story. They said he's asymptomatic. They let him stay in the triage. But this is not acceptable. You have to proceed for endoscopy as soon as possible. I don't care about the MBO status. I don't care that consultant is not available, or I have to repeat X-ray. You have to run for endoscopy. And you have to remove it immediately within 2 hours under general anesthesia, under intubations, considering NGT if there is a severe injury, maybe ENT and pediatric surgery as a backup. You know that honey and sacral fate been studied. Usually we request this if the patient is asymptomatic, but make sure that this will not delay the procedure. But the mother will tell you, or this physician will tell you, why you are in urgent to do this procedure. And the answer for this is simple by 3 things. 1, the electrical injury from the bottom pattery, which is the most important things, because this electrical pattery actually will hydrolyze the tissue of the esophagus. It will lead to liquefaction necrosis, means like an alkaline caustic ingestions. Plus, the pattery itself has a content, liquid content, will make the injury worse and worse. Plus, that the pattery with this liquid and electrical injury, it will stuck into the esophagus, and this will lead to a pressure necrosis. And this is really very serious, because if you leave it for 1 hour, or if you leave it for 4 hours, you will see a big difference. Yes, there is a new patteries now in the market with a protective layer, with a bad taste, and with a liquid inside it. If the child took it, there will be a blue discoloration. But even this, also it can lead to injury. Because if you leave it for 2 hours, mild erythema, probably then ulceration, and by time there will be perforation. And this is when we call about complication. I can list to you more than 10 complications, but I just highlighted the complication that I saw, except of course the aortoesophageal fistula, but I highlighted because it is very important. So the most important thing that usually we see, I'm sure most of you, they saw bottom pattery led to perforation, to stricture, to tracheoesophageal fistula, and the worst case scenario that can lead to death is the aortoesophageal fistula. These are the usual complications that we see, but let us come here to the next case scenario because of the time. I have a 2 years old who present with the symptoms suggestive of foreign body, but he has the red flag symptoms, fever, cough, upper GI bleeding, and it was ingested 5 days ago. No one see this, and you order X-ray and you find the bottom battery. Now, if you remember, it's not the matter of just removing the foreign body. You have to anticipate complication. Having foreign body, bottom battery in the esophagus for more than 5 days can lead to a disaster. So what are these disasters? So as per guidelines, you have to do CT angio, okay, to look for the connection of this foreign body with the aorta, or if it led to a complication. Because if you are in a hurry and you said, no, I have to remove it now, okay, yes, you have to remove it, but you have to be careful. Because once you remove the bottom battery, which is impacted anteriorly into the aorta, and it was embedded into the aorta and making a pressure into the aorta. Once you remove it, a gush of blood coming out, and patient will die in the table. So what is the other scenario? You have to go as per guideline, which we will mention here. So delayed presentation will give you major concern for deep tissue necrosis, perforation, tracheoesophageal fistula, or aortoesophageal fistula. The best thing that you have to do is to order CT angio, okay, to look for any vascular injury, aortic involvement, perforation. So at least you be prepared. And for that reason, you have to involve the ENT, pediatric surgery, cardiac surgery, anesthesia, they have to wear in the same time. So maybe patient need a surgical intervention. So assess before intervention, because the delayed bottom battery ingestions is not a routine endoscopy. It can lead to a life-threatening complication. And here, if you can see, this is the guidelines for the bottom battery ingestions removal. You can see here the delayed one, more than 12 hours. Please consider do this measure before proceeding for endoscopy to protect the patient and to protect yourself, okay? I have this usually with me in my phone, even all the guidelines, because, you know, sometimes you forget what to do. So try to make some guidelines or some algorithm usually in your phone so you can go and check. So how I remove this? So if you have a bottom battery, the challenge is actually removing the bottom battery for many reasons. One of the reasons, it is impacted into the esophagus. يعني it's like a glued into the esophagus. So someone will say, okay, I will take a Rothnet and take it. It will never be taken by a Rothnet. I will push it. It's dangerous. We don't push a foreign body actually. So the only thing that you can do is either to use the rat tooth or the alligator, because they have a good grip into the bottom battery. But sometimes you need to do a good irrigation, trying to manipulate this bottom battery and to remove some of the liquid content of the bottom battery. And then you have to do some gentle rotation without a good pressure, only gentle rotation to extract or to take the foreign body. So let us go to the next scenario. This is a 10 years old who come with the magnet ingestion. This is by mistake. He has no symptoms. X-ray this. It looks down, probably in the right lower colon. Now I have to go back into the basic. Is this appropriate X-ray or not? The answer is not. One view is not enough. And we'll see why. So the gastroenterologists think that this single bottom battery, F1, single magnet. So what he do? Single magnet is easy. So as long as you are sure that it is single magnet. Number 2, you have to make sure again it is single magnet. Number 3, and patient has no symptoms. Number 4, and the magnet is moving by the serial X-ray. So you have to repeat the X-ray, not necessary as an inpatient if single. You can repeat it as an outpatient, and you give him laxative. Easy peasy. This is a single. But unfortunately, this is not a single magnet. When you do a lateral view, you can see 2 magnets embedded together. How we confirm this? Because we repeated the X-ray later on, and it is stuck in the same place. Believe me, this is a disaster, because this is the concept of sandwiching the magnet. So 2 magnets attached together lead to perforation, fistula, etc. So if you look here into this magnet, it looks very attractive for you as an endoscopy to remove it as a one piece. But wallahi, it is not the case. Because this magnet is going through everywhere into the GI tract. It is penetrating the stomach, going into the duodenum, going back into the stomach. it needs surgical removal. So why I'm saying this? I'm saying this because this patient in the ER, once they come, okay, we'll see this as a consult, but this patient need to be admitted under surgery. We'll do the procedure as soon as possible. Because all the example of the multiple magnet, you can see that there are multiple perforation, doing fistulas and etc. So you have to be careful actually in the initial management and the support. And I will not go through this, but just to let you know, once in the esophagus, please go immediately before going into the stomach. You have to reach a foreign body before it goes down. If it is in the stomach, also you have to reach as soon as possible. Okay, so I will deal with the multiple magnet as emergent to urgent. So within actually 6 hours, I have to do the procedure. So the count usually matter with the foreign body of the magnet. Usually order 2 views, surgery involvement from the beginning. So this is the most important things. Now the water beads is something that you will hear from time to time. It is actually it's a small like toys or waters or whatever beads. You put it in the water and it gets bigger 100 times the normal size. So the child take it, he drink water, and in the stomach or the duodenum, it will obstruct the GI tract. And the problem is there is no actually guidelines how to deal with these cases. But as a logic or as a basic interpretation, how I can detect this by imaging? So by X-ray, it will not appear. It won't appear as an X-ray. But the aim of doing the X-ray is to look for intestinal obstruction because it can lead to obstruction. But it will appear if it is bigger in size by abdominal ultrasound. So how we deal with these cases? Once the patient, he ingested this, do X-ray, no obstruction, no symptoms, ultrasound looks normal, probably we have to watch and see. Once the patient has any finding, you have to consult surgery and you do endoscopy trying to remove it because it will be difficult. I never did one, but it looked difficult, but you can take this by Rothnet. Other than this, you cannot do anything. Now, I will not go through the coin too much because I have a lot of things to say after that because coin is important, but it is one of the most common foreign body that we see in the ER. There are 3 scenarios you have to know about. Coin above the clavicle, call ENT. Now, unfortunately, most of the hospital ENT will not do the coin above the clavicle. It's better to be removed by a regiscope because that area is difficult for the flexible endoscopy. So coin above the clavicle, call the ENT, mid-esophagus, take it within 24 hours. If symptomatic or asymptomatic, if the lower esophagus, the same concept. But if you are in an area where there is a difficulty in doing procedure, give glucagon. Now the sharp object. So sharp object, it's another emergency. So how we deal with sharp object? So the issues with the sharp object that it has a high rate of complication, more than 30%. Okay, so and the most area that it's stuck usually in the ileocecal region. So if you see like this, so what you will do? Do I have to do immediate endoscopy or not? Usually this is a long. So we have to have a guidelines. So as NASBGAN, they have the guidelines. There are multiple guidelines, but the basic things is if in the esophagus, please take it immediately. If it is in the stomach, please take it immediately, especially if it is long. But if it is very short, يعني مسمار صغير جدا جدا, and you think it can pass, based on these guidelines, you can actually follow by X-ray. But if it is long, and this is the most of the scenario, usually you need to take it as soon as possible. Now, the final part of this section is how we are going to take this foreign body, okay? Now, you have to be familiar with the tools. The most important tool that you will use with the foreign body removal is the rat tooth or the alligator or the Rothnet. For the coin and the bottom battery, the rat tooth or alligator will give you a very strong grip. Rothnet is very good, especially if it is in the stomach where you have an area to expand your Rothnet, toys, whatever. But if the sharp object usually, so for example, here, food impaction. We didn't talk about food impaction. Food impaction, if you have a child with EUE who comes to you with a food impaction and he has difficulty in swallowing and he has a drooling, he need endoscopy. The first thing when we go there, he said خلاص push anesthesia said خلاص push اللقمة داخل. We cannot push اللقمة داخل. It will lead to perforation, especially if there is a stricture underneath that area like this يعني picture. So what we do, we'll take it. Now some of the difficulty is إذا كانت الأكلة توها فريش يعني ما تكون ما you cannot take it as a one piece. So I find that the best tool that you use it is the tripod. A tripod جيد ياخذ لك grip. هذا tripod. If tripod تدخل وتاخذ one grip, you take it out as a one piece. أنا ما عندي tripod. You can use the rat tooth or the alligator, sometimes the snare, sometimes the roth net, but please don't push it. Okay. Now the sharp object. The best thing to take the sharp object. A sharp object, I have a sharp edge. I don't take the sharp edge facing me, okay? Because if you take the sharp edge facing you, when you pull the sharp edge, you are like scratching or injuring the esophagus. So the best thing is to make the sharp edge facing distally. And I feel that the best tool is السنير. That is the best tool. But if you have a good facilities and you have something to protect this from the scope, like الكاب أو الكوندوم هذا اللي يدخل وفي اللور اسوفيجيال sphincter, it will يعني flip كذا فيكون زي protections around the sharp object. And I think I finished my part of foreign body. And now I will move to Dr. Ghaidaa before I continue. Dr. Ghaidaa.
Yeah. Let me share my screen. أهلا.
I will stop sharing and you can share now. حياك الله دكتورة غيداء دهلوي. She is a pediatric GI consultant in King Abdulaziz University Hospital. And تفضلي دكتورة غيداء, continue your part.
You can see my slide in the presenting mode,
I can't
right?
see, but yes, I can see. تفضلي.
Okay. طيب, Assalamu alaikum. Good evening, everyone. Thank you for all attending, and I hope this is going to be beneficial for you. Okay. So as Dr. Muhammad said, really like the focus of this session is focusing on the clinical purpose and the clinical approach to the to this common scenarios that you're going to face in the clinical life, in your duties or during the on-call, and we are focusing on the important stuff for the exam and also for your real life. So I'm going to start with this first scenario, which is a 2 years old boy who whose mother found him crying next to an open bottle of liquid drain cleaner, which is the sodium hydroxide, 90 minutes ago. Unclear how much was ingested, and he immediately vomited and has been drooling and refusing to swallow. When you examine him, he was tachycardic and bit tachypneic, but oxygen saturation was maintained on room air. He's awake, crying from the pain, drooling actively. When you look to the oropharynx, there were white plaques on tongue and soft palate and posterior pharynx with no stridor. Lung work was clear and abdomen was soft, non-tender. So obviously, this is a case that you are dealing with a caustic ingestion. Before going to the approach to the caustic ingestion, I want to highlight this important clinical clues that really you as a gastroenterologist, you have to understand and know the information before you decide what to do with this patient. So the substance that got ingested, what type of the substance, is it accidental or an intentional attempt? The pH of the ingested substance, also the amount and the type of the substance itself, whether it's liquid, gel or solid, the time of the ingestion, the surface that exposed to, and the symptom that the patient presented with, and really predicting the injury that you're gonna handle with. So whether the patient having vomiting, drooling, hoarseness, abdominal pain, shortness of breath, or bleeding, developmental milestone, and whether the patient having any clinical chronic diseases or disabilities. Of course, you're gonna ask or assess for hemodynamically stability, hemodynamic stability with the vitals, and also the important thing, which is the airway, asking for the stridor and respiratory distress. Also important to examine the eye and oral cavity and looking for any signs of injury on that area, and also any skin findings. And importantly, I want to highlight that caustic ingestion is divided into main two categories, acidic versus alkali. So by meaning alkali is pH more than 7 and reach up to, in severe alkali substance, up to 11 or 12 pH. For the acidic, pH is less than 7, and in severe acidic substance can reach to pH of 2. So the main mechanism of the acidic substance in the injury is the coagulative necrosis, which is this is an area of MCQ. It's very commonly in the MCQ, the mechanism of acidic or alkali ingestion or injury in the GI tracts. For the acidic, it's coagulative necrosis, and for the alkali is liquefaction necrosis. And obviously, we can tell that alkali ingestion is more severe, causing more severe injury than the acidic ingestion. Acidic substance mainly affecting the stomach, while the alkali substance mainly affecting the esophagus because it's get neutralized in the stomach. I put this table just to know the common caustic substance that you may face, and you can appreciate that most of these substances are within the house, so it's very dangerous thing, and really it's shocking for the family. So most of the most common substance that we're facing is the drain opener and the oven cleaner, and also the drain cleaner. So moving now to the acute management of the caustic ingestion, the first thing that is stabilization to the patient, ABC. So airway is priority. Whenever you have patient who have a history of caustic ingestion, if he has stridor, drooling, or hoarseness, you have to involve ENT with you. Then the first thing that you have to ask for is to put the patient in PO, secure an IV access, and start the IV fluid. Of course, you're going to start the patient in analgesia because he's going to be in severe pain causing with this caustic ingestion. One of the important thing that you have to ask for is identify the agent, or ask the family to bring the bottle to know exactly what the substance is and what the pH is. Of course, call the poison control. I don't know. I'm not sure how much it's gonna add to us, but you can do something like that. It's also a medical legal thing to do. Number 2 is assessment. So as I said before, symptoms really predict the injury. So you can know what are you dealing with. Drooling, dysphagia, oral burn, vomiting, hematemesis, abdominal pain, and dyspnea, all of that reflecting whether it's only injury to the GI tract or it's also has some consequences or complication. Also the lab, it's going to help you to detect that. You're going to do the basic workup, CBC, lights, blood gas, lactic acid, and CRP, kidney profile, type and screen. Other important thing to do is X-ray, especially if you are suspecting perforation and upright abdominal film, looking for pneumomediastinum and free air. Consider to do a CT, neck, chest, abdomen if severe symptom, or if the patient is unstable or suspecting perforation. Last thing, when to scope or what you're supposed to do as a gastroenterologist. You are supposed to do an EGD within 24 hours if the patient is symptomatic, and avoid delaying the EGD beyond the 48 hours because the risk of perforation it raises when reach 5 days onward. Grading with Zargar system, and I'm gonna talk about it in a minute. When you are doing the endoscopy for those patients, if a patient is asymptomatic with no oral lesion, just observe, admit him for observation, and observe for and monitor for the feeding tolerance, and no need for EGD at that time. This is the Zargar endoscopic grading, and this is the thing that you really have to look for when you are doing the endoscopy as an assessment, because all the management and the follow-up is going to be depending on that grading system. And this grading system is basically on the endoscopic finding. So it's ranging from 0 to 4, 0 being normal mucosa, and it has a low risk of perforation and low risk of stricture formation. Number 1, grade number 1 is edema and hyperemia of mucosa, and also it has a low risk of perforation and stricture. 2A, which is the first picture in the left, the superficial ulceration, and usually it's longitudinal when you are doing the scope, longitudinal superficial ulceration with friability and exudate and hemorrhage, and also it has a low risk of perforation and stricture formation. Moving to the most dangerous grade, which is the 2B. So 2B is basically 2A plus circumferential ulceration that you can see in the next picture on the left, with a deep ulceration as well, and it has a high risk of perforation, and the risk of stricture is 30%. 3A is the small scattered area of necrosis, which is a black grayish discoloration in the mucosa, and it has also high risk of perforation and risk, and also 50% risk of a stricture formation later on. 3B, which is the extensive necrosis, which is the last picture on the right. Extensive necrosis is critical and have a higher risk of perforation with 100%. This patient will gonna end up with stricture. Of course, perforation is a surgical management. You're going to not do an endoscopy for them. So based on the grading, your decision for the or the management is going to be depending on that grading. So grade 0, 1, or 2A is you can just observe the patient, admit him for 24 hours, and diet as tolerated, then discharge him home. For giving that, the patient or follow-up is reliable for the family. Grade 2B, starting from the grade 2B onward, before the perforation, admit the patient, of course, and keep him MPO, starting BPI, TPN, or tube feeding, broad spectrum antibiotic, especially if the perforation or necrosis is suspected. Placing a feeding tube or NG tube, it should be under direct vision, meaning in the endoscopy or by the fluoroscopy, especially if the grade is 2B or 3, severe grade, and acting like a luminal stent, and also it's helping us when the patient is improving, we can use it for nutrition. Steroid, I'm going to talk about steroid in a bit, but it's one of the treatment line or management line for the caustic ingestion for a high dose of steroid, IV steroid for 3 days. Surgery is kept for cases of perforation and full thickness necrosis, mediastinitis, and peritonitis. Actually, those are some pharmacological therapies that I believe all of you used them before, but it has a limited data on their efficacy, meaning in pediatric there are some study not that strong enough to prove the efficacy. However, still we are using that. It's not routinely recommended in the guidelines, but a lot of consensus and expert opinion, they are supporting that. One of them is the steroid, and the study that like the paper or the study that reported the efficacy of the steroid actually studied on the 2B injury, and they found that it prevents the stricture formation, and the dose, it should be 1 gram per meter square, 1.73 meters square per day. The other thing is sacralfate. Sacralfate acting as a coating and delaying of or decreasing the stricture formation. And there are some study that it's actually based on the case report and also case series and one small randomized control trial that shows sacralfate has a less symptomatic strictures. Mitomycin, which is a fibroblastic apoptosis, has a fibroblastic apoptosis mechanism to reduce the scarring. It works well with a long stricture and refractory cases, and it significantly reduces the clinical symptom of the stricture, and also it works well with less need or requirement of the esophageal dilatation, but still the evidence is very limited on that. So the important thing to know or to consider in dealing with those patients is the long-term prognosis and follow-up. For the injury grade 1 or 2A, no need for follow-up. No need for follow-up with the endoscopy. For the 2B and more, they have a high risk of a structure formation, as we saw before in the table, and they have to have a follow-up endoscopy after the injury by 3 to 8 weeks. The risk factor for the stricture formation, and I believe this, and I brought this up because I believe this important for you maybe to know, and also it's important as an MCQ for the risk factor for the stricture formation in caustic ingestion. Number 1 is grade 3 lesions are strongly associated with a stricture formation with an odd ratio of 11.7, and also acidic ingestion. It's in comparison to the alkali ingestion has a lower likelihood of the stricture formation. And this is all based on meta-analysis and systematic review that done recently. So really the teaching pearls for a case with a caustic ingestion are symptoms drive the endoscopy decision. In patient with who is asymptomatic with no oral lesion and reliable follow-up, no need to do an EGD. But if you have patient who is symptomatic, he need an EGD within 24 hours after securing the airway. Oral lesion is not equal to esophageal injury and vice versa, meaning the mouth doesn't reliably protect the esophagus. Maybe you have a normal mouth, but still the patient is symptomatic and you have an esophageal injury. Always to remember that, always remind myself, alkali go deep, and acidic and substance stay shallow. So the alkali, it's injure the esophagus by liquefactive necrosis, and the acid by the coagulative necrosis. The stricter surveillance start at early as 20 days after the injury or at 3 weeks, and the surveillance should be with a contrast or EGD. The endoscopic balloon dilatation is the first line therapy or approach to those patients. And I think now, Dr. Muhanad, I should hand over to you to go to the bleeding, right?
إلا صحيح دكتورة. دكتورة غيداء, very nice. Thank you for your presentation. One of the important things that usually come to the ER, the scenario of a child who has caustic ingestions, he has some mild edema or swelling on the lips, but he is asymptomatic. Here, the decision what to do. Okay, so he's now in the ER. Are you going to admit him for observation? Are you going to do for him scope? Are you going to give him medications? What you do with these kind of scenarios?
Actually, like for me, I know this is like a cold case. So when you see this, since there is some of the like mild symptom or mild finding in the oral cavity, maybe I will admit the patient and keep him on observation. Maybe I would start on PPI, but it depends on his tolerance and his progression during the 24-hour. I won't do the AGD. So I cannot say it's like one definitive answer. It's case by case. So for this patient, I would be conservative, but maybe I would start a treatment like an PPI, but not like to do an endoscopy for him. I don't know. Maybe you
Perfect.
have
And what
like
I
a different
usually do,
opinion.
I agree with. No, I think this is what I usually say. He has mild lip swelling and he
Yeah,
is asymptomatic. So the first thing, I will not send him home. خلاص
yeah,
اتفقنا.
of course.
Number two,
Yeah.
I can help him by give him dexamethasone, but a small dose, the airway dose, اللي هي
Mm-hmm.
أظن 0.6 أو كذا. It helped to decrease
Mm-hmm.
the swelling. But I agree with
Mm-hmm.
you. Usually when I say endoscopy, what it will change in the management, except you see
Exactly.
some esophageal injury that you might think about giving a steroid, which is a controversy. So
Yes.
usually this the thing that I do, but thank you, was very informative, Dr. Ghaida. Now let me go through quickly because we have still a lot of emergency. Now we'll talk about upper GI bleeding. The scenario is as follow. This is an 8 years old, come with a 2 episode of hematemesis, large. Plus, he has epigastric pain, he take ibuprofen, and he is pale, tachycardic, delayed capillary refill time, and the blood pressure borderline. So the questions for the resident is what to do next, not for the fellow, because I'm sure the fellows, they know. So you will do the ABC. Now it comes to you. So usually what they will do in the ER, as a GI fellow, they will call me and they will tell me about this scenario. Please make sure during the interview with the ER physician that you know that the patient is hemodynamically stable or not. You take a brief history, we'll talk about it, and you make sure about certain things on physical exam and lab. Because based on this, you will make the next decision. How many times they call you about a CP patient who has a coffee ground vomiting and he's totally fine? What you will do for him? In the other scenario, a 4 years old who has a GI bleeding, upper GI bleeding, previously healthy, and he has a splenomegaly. So there are few things that you have to analyze from the first impression in order to decide about the management. So airway breathing, this is not my duty, but I have to make sure that everything is fine and ER physician, they are happy. But I highlighted the important things for you as a fellow or as a GI doctor. Please don't accept the patient unless as much as you can that he has two large pore IV cannula. Because you need this for anesthesia, you need this if patient has bleeding or if you need to give him octreotide, for example. And of course, you keep the patient MBO. تقول لي لا حرام مسكين ما هو حرام مسكين you have to keep him MBO till you decide about the next step of management and then the resuscitations please avoid the over resuscitation especially if you suspect varices but you don't make the patient dry so if he need fluid give him if he need blood give him now if he need blood what do we mean if he need blood يعني لازم يكون عندنا numbers if the hemoglobin is less than 7 أو 8 مع tachycardia وأشياء ثانية. And please don't forget the order group and a cross match because you need it in the anesthesia and otherwise we're going to poke him again and we take the blood again. Now, correcting coagulopathy is not allowed if the patient has a chronic liver disease. But if the patient is not known to have chronic liver disease and he has, give him vitamin K. You can give him platelet if it is low, but not in cases of cirrhotic liver. And start him on PPI. So you, as a GI fellow, we highlighted the important things by phone to be done, when to give blood, when to do to give a PPI. So now taking the history. This, I put it like this for like the OSCE preparations. Few questions to ask in order to pick the possible etiology. So if the baby is low thought vitamin K deficiency, but if he has recurrent vomiting, and we see this a lot مع neurodevelopmental delay with CB, they have significant erosive esophagitis, so I'm sure that you did scopes and you find this, or gastritis or peptic ulcer disease. Or if a child has a sickle cell anemia, he take ibuprofen all the time, and he develop peptic ulcer disease. ورقم 4 that I would like to highlight again and again, think about bottom battery. لو 100 حالة سويت فيها واحدة وطلع bottom battery, that's okay. Family history of peptic ulcer disease or history of liver disease. Now I have a very important clue to categorize the patient in which etiology. On exam, please do appropriate exam. Don't depend on other physician. So what is the appropriate exam? You have to look for any tenderness. I have a patient who comes with the upper GI bleeding. He has severe tenderness and then found to have a duodenal perforation from the duodenal ulcer. He has air under diaphragm. This, if you did not pick it before the endoscopy, they will blame you. When you do the endoscopy and there is a perforation, they will say, once you are going to the duodenum, you perforated the ulcer. So please make sure if he has tenderness, at least put a baseline X-ray for the perforation. And then liver disease, وهذا أهم شيء اللي هو splenomegaly. Now خلاص I have a clue from the history, I have a clue from the exam. What are the categories of the causes of upper GI bleeding? It is different from kid to kid. So if he is a neonate, think about these things. For example, if he vomit bloods, everything is fine. It could be one of the manifestations of cow milk protein allergy, or the other things like swallowed maternal blood if he's 2-3 days, or vitamin K deficiency, etc. But when we talk about older age group, think about caustic or foreign body ingestion, like Dr. Ghaidaa mentioned, or severe erosive esophagitis, or malarious, or H. pylori, or gastric or esophageal varices. And this is very important. Delphi lesion, which is very rare, but you have to think about it if it is really massive bleeding along with the vascular malformation. Similar things to the children at the older age group. Now I will order some investigation. This will help me in my decision in doing scope, and I will answer how. So you have to have a CBC to see if there is a drop of hemoglobin. You have to do coagulation profile in order to do the procedure. And if it is low, you can correct this. Oh, hi, Afwan. You have to do renal function, liver function, cross-matching, blood culture, and chest X-ray. And then you're going to decide about doing urgent endoscopy, like within 24 hours, or elective endoscopy. So خلاص الآن أنت you have the decision. You would like to talk to your consultant or talk to yourself what I will do. But some questions will raise. Do I have to start him على PPI before the procedure? Do I have to give him continuous or intermittent PPI? Do I have to insert NGT? What's the role of octreotide in non-variceal bleeding? Any role of tranexamic acid? All these questions will come to your mind. If it didn't come to your mind, the ICU doctor will call you about these things. So let's start with the PPI. PPI is a very good medication. And the aim of the PPI actually is to prevent the rebleeding again. Keep in mind that all formulation of PPI, that there are no difference between them. And multiple trials done in pediatric and adult showed that there is no difference between IV intermittent PPI versus continuous PPI. So why we start the continuous PPI and we stress on it? To be honest, sometimes we need to start continuous PPI. And these scenarios, like patient in the ICU has severe upper GI bleeding, I will start him. Patient, when I did the scope, I found really very large ulcer, I will start him. If he have recurrent bleeding after the endoscopy, also I will start him. So if he has any high risk, we can start him. But talking about evidence that there is no significant difference between both groups. But otherwise, I will give him a high dose of intermittent PPI. One will ask how the PPI will work in the GI bleeding. We know in the stomach, if there is an ulcer, the gastric acid will make the blood clot into the ulcer weak. It will impair the platelet function, so leading into recurrence of the bleeding. So that when you give the PPI, it will block the proton pump in the parietal cell. So what will happen if you block the parietal cell? The gastric acid will be high, and this will help into the platelet aggregation. It will help to stabilize the clot formation at the ulcer, and this will lower the risk of the rebleeding. So this is why we use PPI in patient with upper GI bleeding. One will ask, طب why not to do an NG? NG is a good thing. The aim of the NG is to determine the rate of the gross bleeding. Do we have a very active huge bleeding? Also to differentiate between upper and lower GI bleeding. But you don't need it all the time actually. And you have to think about it 100 times before doing it in patient who has varices or caustic ingestions or severe coagulopathy. It's useful sometimes, especially in the ICU, but keep in mind the caution that I mentioned. Do I have to use octreotide? How many times the ICU doctor will call you in a patient with upper GI bleeding, non-variceal, please start octreotide. We discuss the case and we need to start octreotide. So we'll tell them the pediatric evidence is weak in octreotide for non-variceal bleeding. And this is based on a study. So there is no strong evidence in giving octreotide. But you have to be flexible because at some cases you might consider if you have severe uncontrolled bleeding, if you have unclear etiology, you can start an octreotide and you have to follow the patient. But in most of the scenario, there is no rule of octreotide. Now, and I know the history, I know the exam, I order the initial labs. Now it comes to your decision, yeah, بطل. What you will do? I have to do urgent endoscopy? Oh, no. I will see him in the clinic, I will admit him and see. وهنا أتى شيء اسمه Sheffield scoring system. هذا it will help you to stratify your patient either high risk أو low risk. What is Sheffield scoring system? Sheffield scoring system هو السكورينج سيستم الوحيد اللي هو validated في البيدياتريك to predict the severity of the upper GI bleeding, to predict the need of urgent therapeutic endoscopy. بمعنى آخر إنه doing this score it will help you إنه إذا كان عالي معناها if I did scope most likely I will do intervention. Okay? أو إذا كان low معناها most likely إنه nothing will happen. بس إنه I will بس دخلت وسويت وطلعت. Okay? So it is very helpful. It was validated in other study. It has a negative predictive value of 88. يعني دخلت وهذا ولقيته negative 88% إنه ما في شيء. Keep in mind this is score. Your clinical judgment is very important. We don't depend about only scoring. Okay? So what is this score? هذا السكور يعتمد على 24 points. 3 things فيها history. هل عنده significant pre-existing condition؟ هل عنده melena؟ هل عنده large amount of hematemesis؟ 1 قليلة هذه. لكن الهارت ريت برضو قليلة. الكابيلاري ريفيلينج تايم وهذه something يمكن subjective يقول لك إنه عنده delayed أو لا you have to make sure by yourself it is high score. الهيموغلوبين دروب is 3. إذا كان يحتاج فلويد بولس كمان 3. إذا كان يحتاج blood transfusion هذا 6. أوكي أو other products. متى أقول إنه هذا عالي إذا كان أكثر من 8. Let us apply this to our patient. هذا our patient عنده large amount of bleeding. His heart rate is high. His capillary refill is high. And his hemoglobin is dropped. And he requires transfusion. So this is high. يعني he need urgent endoscopy. عكس المريض اللي عنده CB. اوكي وعنده بس كافي جراوند فوميتنج هذا ياخذ لور وعنده نورمال هيموجلوبين نورمال everything. طيب الان سويت الاندوسكوبي في شيء اسمه فورست كلاسيفيكيشن you have to be familiar with it. طب why I have to be familiar with it? This is an adult classification. This is yes adult but can be applied in pediatric because no we don't have other alternative. So if you go here and you find this ulcer into the stomach, this is a very nice clean based ulcer. طب هل معناها شيء؟ How forest classification will help me in this picture? Another picture, this is an ulcer with a visible vessels with oozing of blood. هل يفرق عن المريض قبل؟ And this is a spurting of blood. A good thing we don't have a lot of ulcer in pediatric, okay? We have only very limited cases. A forest classification, the aim of it is to tell you that this patient, if you leave it without intervention, there is a risk of rebleeding. فتخيل هذا المريض لو تركته قلت لا إن شاء الله يطيب، هذا عنده ريسك اوف 100% recurrence of bleeding. لو تركت هذا المريض اللي عنده visible vessels موجود وعنده oozing of blood، هذا عنده 50% recurrence of bleeding. لكن هذا المريض ما عنده شيء، هذا بس clean base ulcer 3 to 5%، معناها you don't need to do anything for it. لكن the other patient you need to do. فهذا it will help you that you have to do intervention on these scenarios. Okay, so let us wrap it all. هذا المريض عنده classification 2A. He has high rebleeding risk. You need to do endoscopy, combo, adrenaline plus clip, and he need medical treatment. We don't need to repeat endoscopy. دكتور ثاني غير محظوظ سوى اندوسكوبي ولقى الألسرة المحترمة هذه وفوقها كلوت. السؤال الذي يتبادر إلى الذهن do I have to remove the clot or لا؟ وهذا السؤال يعني سؤال المليون. do you need to remove the clot أو لا؟ وهذا جيد جدا لأنك أنت ترى الكلوت هذه مرتاحة جدا في الاستومك، أنت you are looking for it، قلت I have to leave it and remove it. You remove it and the monster will come. There are bleeding vessels. So what is the answer? Do I have to remove it أو لا؟ The answer is the clot is considered high risk for rebleeding. If you go to this scoring system, adherent clot has high risk 20 to 30% of rebleeding. So you have to think about removing the clot, expose the area of the bleeding, and you have to do the definite treatment. Okay? We have to make sure in the patient على PPI. But I have هنا one thing I have to mention. Please don't do this if you have don't know يعني no much experience أو ما عندك good equipment أو ما عندك packs يعني support. Because إذا حصل هذا الشيء أتركها في سلام إذا ما عندك هذه كل الأشياء، أو إذا عندك ف you have to do it. Okay? Adult expertise في other المستشفيات يكون دائما بعض الأحيان الأدلت موجودين. Okay? طب how I remove it؟ فالطريقة كالتالي، وهذا ما هو كلامي، هذا published في الجايدلاينز والبوزيشنز بيبر on كذا. inject adrenaline around the base of the clot عشان temporary إذا كان في vessels it will stop bleeding, and then remove the clot by a snare. وعاد أنت وحظك إيش حيطلع. إذا لقيت في visible vessels do the clip، وهو the best thing to do mechanical يعني blockage. Okay. الآن what are the endoscopy toolkits? You have to be familiar with this. Some hospital they don't have, some hospital they have. أهم شيء you have to be familiar مع ال ABC، مع ال heater probe، مع ال hemoclip، مع ال injecting needles. هذه you have to be familiar with it and how to use it. Okay. I will not go through everything because this is not our aim, but you have also to know what is the age of your patient. إذا كان البيبي صغير يحتاج neonatal scope you cannot have only the ABC أو ال injecting needle. But the other babies you can have كل شيء تقدر تسويه، يعني snare وكليب و everything. Okay. ف these are the therapeutic modalities you use يعني for hemostasis. I will not go through it, but the only thing that you have to know that when you control the bleeding you have to have a combo of two. combo رقم واحد to settle down everything، يروق الجو. Okay. adrenaline inject، قفل البليدنج for 15 to 20 minutes حتى انت تاخذ راحتك and you do clip او ABC او cautery. فالادرينالين will stop the bleeding temporary، بس the second modality will prevent a rebleeding. طيب how I inject الادرينالين؟ تاخذ الادرينالين تستعيرها من الانستيزيا 1 in 10,000، تاخذ منها 1 ملي، you dilute it into the 9 ml of normal saline and you take it and you inject into the 4 quadrant of the ulcers. And I don't do in the center but in the 4th ulcers, and then you do the definite treatment either ABC أو الهيموكليب. الآن إذا كان المريض لسه عنده bleeding you have to reassess the situation again, revisit your diagnosis. يمكن you have to do the endoscopy again. You have to do you have to make sure إنه يكون عندك pack support يعني زي الادلت هيموسبراي. البالون tamponade is also effective if you are familiar with it, and call for help also. Now I will go quickly into عشان الوقت على الفاريسيال bleeding. أنا أو أي أحد إذا جاك في الطوارئ he's known to have chronic liver disease with bleeding هذا ياخذ باثوي لوحده. إذا جاك عنده suspicion of portal vein thrombosis يعني عمره 3-4 سنوات وسبلينوميجري low platelet، هذا most likely portal vein thrombosis، هذا لوحده. اوكي، فهذا you have to deal with them as an upper GI bleeding with portal hypertension. I will not talk about the other thing, but here I highlighted important things about use a restrictive strategy in the transfusion لأنك أنت you are overfilling the vessels and it will ruptures. Cirrhotic liver they have risk of sepsis and you give him antibiotic please. Okay, عكس ال other patients، هذه extra. Okay, ectotide is very effective. You use it from the start of the ER visit. You give a bolus followed by continuous infusion. إذا bleeding high you can reach up to 5 mic per kg per hour. This is a must. Okay, and when you do the procedure you don't stop electrotide all of a sudden. You have to continue both endoscopy يمكن for 2 to 3 days and you stop it in a weaning process. This is a lifesaver for you. هذه خفف شوية البريشرز. Okay. A side effect, all of you know, it has risk of hyperglycemia. When to do the endoscopy, I don't rush like this. It is very serious when you do endoscopy. The patient is hemodynamically not stable. The patient wallah might die from the procedure itself and they will blame you. Try to stabilize the patient and then do the procedure from 12 to 24 hours. Okay? الآن what to do with the procedure. صراحة أنا أشوف الباندing one of the important skills for the endoscopist أو GI fellow that you have to master. Do I have to do banding or do I have to do sclerotherapy؟ طبعا الباندing is أفضل، لكن إذا جاك بيبي صغير وزنه أقل من 10 كيلو you cannot insert الباند، يعني اليومن ضيق. أوكي، أو بعض الأحيان لما يكون الفيرس مرة كبيرة وتورشوس وكذا better to do sclero at the beginning. أوكي، هذه أجمل منظر أشوفه أنا أرتاح لما أسويه لأنه يخف التوتر. لما تشوف grade 1 small فيركس تحط اير تختفي. هنا يبدأ الموضوع ياخذ منحى ثاني لما تشوفها grade 2 enlarge occupying less than 1/3 بس لما تحط اير ما تختفي. اوكي، وهذا المنظر المخيف when you see it kissing two vertex together. هذا very risky and you have to manage. احنا we manage which one and I forgot to mention a grade 3 esophageal vertex, grade 2 with red signs أو signs of bleeding، أو grade 2 خاصة إذا كانت كثيرة. فالأفضل إنك أنت you do the banding. أوكي، هذه هي الساينز اللي أنت تقلق منها اللي هي red signs, cherry red spots أو diffuse redness. هذا معناها patient anytime he might bleed. أوكي، I will leave this to you. I will send it to you. I will not talk about how we do the banding. أنا حطيتها كsteps عشان exams أو كذا. هذه complications I will not go through it. الآن متى يحدث الريبليدنج؟ الريبليدنج تعريفه أو تريتمنت فيلر إنه البيشنت بعد ما سويت له باندنج وهذا يحدث إنه يحصل له ريبليدنج again within 5 days. وهذا هنا المشكلة. You have to repeat endoscopy. Make sure you have another colleague with you to help you. You continue tide. You continue antibiotic. Think about doing a balloon tamponade. Think about definitive أو bridge therapy like patient عنده chronic liver disease. I will use the tips. Patient عنده portal vein thrombosis الميزوركس. I do referral to other centers. It will help you. وهذه آخر slide. It summarize everything for the GI bleeding مع الفيركس. أول شيء ABC ectotide antibiotic restrictive transfusion، لا تعطي كثير رجاء FFP، أسوي الاندوسكوبي، الجرين كذا أسويها، الجلو إذا كان gastric varix وأنا عندي competent skills to do it، بعدين تسوي البروفلاكسز later on. أنا بهكذا انتهيت يا دكتورة غيداء. أسلم المايك لك، تفضلي.
الله يديك العافية دكتور مهند. Let me share the screen again. Okay, now we're gonna move to the cases for IBD, the thing that I love. So we start with this a common scenario that you face or you get called for that 11-year-old boy who's a new presentation. This is the first time for him being presenting to the emergency department with a chronic history of bloody diarrhea. It reached up to 9 stools per day with nocturnal stooling. He had a 4 kg weight loss in the previous episode in that period, crampy lower abdominal pain before defecation, urgency, and tenesmus. In the exam, he looked pale, tired appearing. He had also a mild diffuse abdominal tenderness without rebound, and there is no masses. Anal examination was remarkable. So your impression, mostly, this patient could have infectious colitis versus an IBD, and more specifically, you as a gastroenterologist to say this mainly the presentation of UC, or it could be Crohn's colitis, but it's pointing toward UC here based on the exam, but it's not enough. Maybe we have to have more workup to prove that. So you proceed with the workup, and you did a stool study to rule out an infection, and actually it went it came back negative for bacterial pathogen, oviparasite, and C. diff. And when you did the fecal calprotectin, was more than 1800. So at that time, as a regular scenario or common scenario that we face, we planned for endoscopy for this patient to rule out an IBD. So you did an EGD, and it was a remarkable colonoscopy. It showed continuous severe pancreatitis with deep ulcers with a USS score 7 and Mayo score 3. And I will talk about this in a bit. Histology or histopathology report consists with the UC. And the thing, and this is the important clue or terms, pathological terms that we can see in the histopathology report that pointing toward UC diagnosis. The evidence of activity, cryptitis, extensive crypt abscesses, increased lamina propria cellularity, mucus depletion, and no granuloma. People who, anyone who works with me from the fellows know that I really don't like a mayo. Don't get me wrong. It's not like it's a standard one. And it's the thing that it's easy and practical. And most of the guideline recommend that. And also most of the trials in the literature, they are using that for the comparison and also for the diagnosis. But for me, uses for the gastroenterologist is more meaningful and also more informative, especially when you are doing a follow-up. So just I want to highlight this. I know this is not something for the like an acute management, but I want really to take that chance to highlight this, that you have different scoring for UC by the endoscopy. There is UCs, there's Mayo, and there's other scores, but those are the most commonly one that use. So you can see based on this patient, he has a severe pancreatitis with deep ulceration, I would say, based on this picture, Mayo 3, and also uses 7 to 8. So like the message from this that I brought it up here, that whenever you are reporting an endoscopic finding for IBD patient, please write like describe whatever you're seeing. Describe 4 things. The vascular path, whenever you are seeing like a picture by the colonoscopy, describe 4 things. And you're gonna score those 4 elements: vascular pattern, bleeding, erosion, and ulceration. And the 4th thing is the mucosa. This thing is going to help you to decide whether this patient having a severe and the severity of the endoscopy finding. And also it help you when you are doing the follow-up later on, which one is disappear and which one is improve or not improve. I know you said it's very expensive scoring, and maybe you're gonna prefer to do Mayo just for the practicality and also easy to use. It just, for me, it doesn't matter for me to use Ayusis or Mayo. It just, the description is matter. So for back to our case, when you do so this patient is confirmed to have a UC, and based on his symptoms, if we do the Bukai score that all of you know about it, which is the component of it: abdominal pain, rectal bleeding, stool consistency, the frequency of the stool, nocturnal stool, and activity. If we get back to our case and calculate his Bukai score, the total is 85, which is indicate acute severe colitis. And just as an interpretation for the Bukai score, and all of you know that Bukai score is an international validated score that predicts and also correlate with the disease activity in the ulcerative colitis. So really the interpretation and the score for the Bukai for your patients, it affects your decision in the treatment or the managing those patients. So remission is less than 10 to 35 is mild, and you can manage the patient as an outpatient. And for the moderate is 35 to 65. You can consider outpatient management if you have a guarantee follow-up, or the patient is safe to be follow-up as an outpatient, or you can consider admission. For severe acute colitis, like our patient, he need to be admitted and start IV steroid. This is my beloved algorithm in the whole IBD. And really this algorithm that you cannot graduate it without knowing this algorithm. This is very important. Day 3 and day 5 of admission for any patient admitted with acute severe colitis is a time changer, or it's a game changer, sorry. So whenever you started in day 1 to day 2, when you start IV methylpred with a dose of 1 to 1.5 milligram per kg up to 60 milligram in one or divided doses. There's no evidence of getting or exceeding 60 milligram. If you have an obese patient or an adolescent patient, there's no evidence to get up to exceeding more than 60 milligram. So the maximum is 60 milligram. And if the patient is already diagnosed with acute severe colitis and he was on conventional therapy with the 5-ASA, in the algorithm or in the guideline, you have to withhold the 5-ASA. But if he's freshly diagnosed, you just proceed with the IV steroid alone. Of course, you have to consider that the patient could have an infection. So you have to rule out an infection and C. diff specifically. If you have any concern about the toxic megacolon, I will not talk about it now. I will talk about it later. You're gonna consider you have low threshold to order X-ray for the patient. So then moving to day 3. So in day 3, and this is an important day that you want really when you are dealing with acute severe colitis to know what is the patient Bukai score. So if his Bukai score is less than 45, so we are good, and the patient is going in the right direction. So we're going to continue on that, and possibly the patient in coming days, he's going to be discharged and he going to be in remission. But if the Bukai score is more than or equal 45, at that time you have to think about the second line therapy, which is the biologic, and you have to start investigating for the screen for the pre-biological investigation, and also at that time, you can consider also ruling out other infection, because while this patient is not responding properly for the steroid, so at that time you have also to consider that is this patient having a CMV, which is one of the things that is common in IBD patient. So you have to consider in day 3 sigmoidoscopy to rule out a CMV colitis. Then moving to day 5. So in day 5, you have 3 options: Bukai score more than 65, Bukai score less than 35, and Bukai score in the middle between 35 and 65. So for Bukai less than 35, we are good. Patient going to be in remission, hopefully, and he's going to be discharged home soon. For the Bukai score of more than 65, meaning it's really, really a dangerous time, and it's a patient in danger, and also it's a time to act. It's not a time to decide. It's or to think about biologic. It's a time to start the biologic actually, and not to be delayed more than this. So at that time, you're going to start the second-line therapy. In the guideline written, infliximab, tacrolimus, and cyclosporin. Of course, like we know all of us that more of us are familiar, and also a first line for us as a second line therapy is infliximab or anti-TNF. If the patient have a Bukai score between 35 and 65, at that time, meaning the patient is in the middle, maybe he needs some days to be to improve, and he needs maybe some of push to improve. Like you can maximize the dose of the steroid at that time. This is one approach that you can do. You can also investigate for the infection if you didn't do that before. You can add some like mesalamine at that time that can help the patient to go to the remission. You can add some of the antibiotic cocktail like vancomycin, ciprofloxacin, and metronidazole that can help settle the inflammation. So those are the options that you can do in that situation when you dealing with Bukai score between 35 and 65 in day 5. And after that, for the patient with a Bukai score of 65, you're going to go towards the infliximab. And I want to emphasize about the infliximab dosing in the acute severe colitis to be in the higher end. Never use a dose of the standard dose of 5 milligram per kg in acute severe colitis. You have to go high, and the evidence for that, there are a lot of study that written or reported in the literature for the evidence of the highest high dose of infliximab to prevent the risk of colectomy in the follow-up period after after 6 months or after 2 years. So start with a high dose of 10 milligram per kg, and also preferably to start with accelerated also dosing or accelerated regimen. There are a lot of study that compare accelerated regimen with a standard regimen. What I mean, the standard regimen is 0 to 4 that we know. This is the standard regimen. The accelerated regimen is 0, 1, 2. So as in the guideline and based on a lot of study, the accelerated and high dose of infliximab, it's gonna prevent the colectomy, and also or it decrease the colectomy risk in the future, and also decreasing the risk of flare-up later on. Important consideration in managing acute severe colitis, and those things that very important that sometimes we are not giving any attention to it, but this is important to consider for the pain management. Hot bags and paracetamol for the pain management. Try to avoid NSAID as much as you can in acute severe colitis, because it can precipitate to toxic megacolon, as well as for the opioid. Consider when you're managing, and this is align with treat to target, because always for us, we are forgetting the nutrition when we are dealing with IBD, and also and always we are focusing on the pharmacological therapy. So nutrition is very important when you are dealing with any patient with acute severe colitis, because they are in the catabolic state at that time. So he can eat. So regular diet should be continue. Enteral nutrition or parental nutrition, if oral feeding is not tolerated, or if the patient is severely malnourished, can be considered. And also the thing that you have to focus on, that monitoring closely for any patient presented with acute severe colitis or severe ulcerative colitis and he's severely malnourished, to closely monitor for refeeding syndrome. Lastly, VTE prophylaxis, and this is really a debatable thing. There is a mixed result in the literature about the effectiveness or the indication for the VTE prophylaxis. And actually, in the last position paper in the GBGN in the ECHO guideline for the starting the VTE prophylaxis for the acute severe colitis, they recommend that, especially for patients with acute severe colitis and having other risk factor. As we all know that the risk factor for the thrombosis in the children in general is less than the adult. But being an IBD, it's increasing the risk than the general population by 1 to 37%, higher than in 100,000 population. So still there is a significant risk. It's lower than the adult, but still there is risk. And they recommend in the last position paper to consider starting the VTE prophylaxis when there is more risk factor. And what I mean by the other risk factor for VTE is patients who are very young and newly diagnosed with a UC. He's already in systemic steroid, which is all the scenario for patient with acute severe colitis, patient who you're going to be considered to start a JAK inhibitor, patient who went to recent surgery, he is like bedridden or complete embolization. If you have a central venous catheter, having a history of previous VTE, or having a family history of bleeding disorder or coagulation disorder, in the adolescent, if the patient in oral contraceptive or hormonal therapy, if the patient having any risk factor or signs of metabolic syndrome like an obesity and hypertension. All of that, it increases the risk of the VTE, so you have to consider that in your management. So as a teaching purpose for acute severe colitis, and really I want you to remember those numbers. It's important in your exam, in the MCQ, and also it's important in your clinical life to remember that. Like almost 28% of patients with UC will have an acute severe colitis, and 40% of them gonna fail an IV steroid and gonna require anti-TNF or biologic or the second line therapy. Day 3 is the decision point for the rescue. It's not day 5. Day 5 actually it's applying your decision. So you have to think early in the treating patient with acute severe colitis from day 3. Bukai score is your scoreboard. So I'm expecting from any gastroenterologist who are dealing with acute severe colitis to have a Bukai score written in each day that since the patient got admitted to the floor. So it has to be calculated daily, and it's really a most sensitive marker, and it's an objective actually marker to record the response and also the progression of the disease better than the CRB. Because most of the UC patients, or not most of them, I mean, like there is a good number of UC patients, they have like normal lab, like normal hemoglobin, normal CRB, normal albumin. So Bukai score, really, this is the way to go when you are dealing with acute severe colitis. Always, whenever you have patient with a flare, especially with acute severe colitis, look for the infection, because those IBD patients they are colonized with a C. diff and a CMV, and they have a higher risk than the general population for those infection, especially the steroid refractory acute severe colitis. And consider that before escalating the therapy, maybe they just have a C. diff or they just have a CMV, and no need for you to escalate the therapy. Albumin really matters, meaning when you are talking about pharmacodynamic and pharmacokinetic of the anti-TNF, specifically infliximab, albumin, one of the things that you have to put in your mind, what the albumin of this patient. And from this, it's brought the significance of using a high dose of anti-TNF or infliximab and accelerated therapy, because albumin is reflecting a severe disease or like leaky gut. So the albumin is lost in the in significantly in the stool. So hypoalbuminemia accelerate the infliximab clearance. So if you give the patient 5 milligram per kg, he will not be benefit from this dose because it gets secreted or cleared because of the low albumin. So for that reason, always we recommend, and this is actually mentioned in the guideline, use the intensified dose, which is the 10 milligram per kg with a shorter interval and accelerated induction regimen. Now, moving to the case number 3, which is somehow related to the case number 2, which is the acute severe colitis. So this kiddo, 14 years old girl with established diagnosis of UC bank colitis, diagnosed 3 years ago, and she is on oral Pentasa. Just 2 weeks ago, she had a symptom of bloody diarrhea, 15 stools per day, and crampy abdominal pain. And presented to the emergency department 36 hours ago with acute severe colitis. And you already know what to do with the acute severe colitis. You started her on the IV methylbride 1 milligram per kg, and you admit the patient and you calculate the bucci, and everything went good. The second day, when you come and visit the patient or review the patient, like the nurses tell you that the stool have paradoxically decreased, and I think you were happy about that. But at the same time, she's more lethargic, and the abdomen is markedly distended and tender, and the bowel sound are absent. When you assess her, hemodynamically, she was really unstable. She was tachycardic, a bit hypotensive, and febrile, and maintaining oxygen saturation in room air, but she's tachycardic. Also, when you do some lab work because of the deterioration of her clinical status, however, she was really in the symptom improved in terms of the stool frequency. I mean, you order for her CBC, and you find that she had leukocytosis, low hemoglobin, but still the same, low albumin and high CRB, and disturbance in her electrolytes, mainly the potassium, and also high lactate. At that time, you have really to consider that the patient is on risk for toxic megacolon, or this you are dealing with a toxic megacolon. So you have to order immediately an X-ray to prove that. So how we diagnose toxic megacolon? So this is the criteria from the guideline that published long time ago in 2018. Suggested the pediatric criteria for diagnosing toxic megacolon. So it's not only the radiological finding, but also it has to have also the evidence of systemic toxicity. So for the X-ray, when you order the X-ray, the definition of megacolon is when the transverse colon diameter is more than or equal 56 millimeter in patients who are more than 10 years, and more than 40 millimeter in patients who are less than 2 years. Plus, this is not enough to call this patient as a toxic megacolon, plus evidence of systemic toxicity like fever, tachycardia, dehydration, electrolyte disturbance, hypertension, shock, and altered level of consciousness. This is what exists in our patient in the scenario. And this is just a one picture. I mean, maybe you will not see it like an obvious like that, but always you have a radiology to help you in doing this. But most of the time, most of the toxic megacolon that I face like earlier, they were really significant, and it appear like that in transverse colon to be really dilated. So how we manage those patients or this patient with a toxic megacolon? So in the first hour, resuscitate. So keep the patient MPO. So this is the opposite than the acute severe colitis, because in acute severe colitis, we allow the patient to feed. But in toxic megacolon, this is the difference. Keep him MPO and do the nasogastric decompression, and 2 large pour IV and give them bolus, especially this patient who have an hypertension, and start him on IV fluid. Correct any electrolyte disturbance aggressively, because all of this increasing the risk factor to progress the toxic megacolon to perforation or to be failed at the medical therapy. To do band cultures, stool CDF, and also culture for any bacterial pathogen. Start the patient in broad spectrum antibiotic to cover gram-negative and also the anaerobes. The most commonly antibiotic used in that situation is biptezo, but you can use other regimen like ceftriaxone, like third generation cephalosporin plus anaerobe coverage like vancomycin or metronidazole. At that time, when you admit the patient with a severe pain, like abdominal pain, stop and say, please, because it's gonna also exacerbate the toxic megacolon. Then you have to start the patient on IV methylbret with a dose of 1.5 milligram per kg with a maximum of 60 milligram. When you are following up on this patient, you have to have a daily, of course, like daily abdominal exam clinically, and also daily abdominal x-ray to see the progression of his megacolon. From day one surgery, they have to be on board with us, even if they are not doing an active thing, but they have to be involved from day one. And of course, for those patients, because the classical teaching says whenever we have patient with a flare, maybe we'll think about doing a scope for them. But in this situation with a patient, especially this patient, she was diagnosed 2 years ago and she was really fine the whole 2 years. Just now she came in with this. So avoid the colonoscopy at the setting of the toxic megacolon, because it's going to increase the risk of perforation. Or any like contrast enema or any imaging that need in contrast, or any type of imaging in that setting of toxic megacolon. When you're gonna consider calling the surgery, and the surgery, they're gonna be the one who are taking the lead for toxic megacolon, when there is a free perforation or pneumoperitoneum, that's obvious in the x-ray that you did. If there is a massive hemorrhage that requires ongoing transfusion, if a worsening dilatation in the serial abdominal x-ray that you are doing in the first 24 to 48 hours of the medical therapy, meaning it's refractory to the medical therapy, or clinically the patient is worsening, and if there is a multi-organ failure. So teaching pairs for this case of toxic megacolon, 5 to 10% of pediatric acute severe colitis can have a toxic megacolon, which is not a small number. Actually, it's a big number. So you have to be conscious about it and caution when you are dealing with a patient with acute severe colitis. They may develop a toxic megacolon at any time. So decreasing stool frequency in sick colitis is not an improvement. Don't be happy about that. You have to take the patient as a whole and see if he's improving in the stool frequency. It doesn't mean this, meaning the colon is shut down. It's not improvement. Significant abdominal pain and tenderness in acute severe colitis is really a red flag, which is the opposite than any patient with a Crohn's disease, which is expected. Any patient with Crohn's disease may have abdominal pain or significant tenderness in the abdominal pain, because most of the Crohn's disease affecting the small bowel, which which I'm not gonna be surprised. But in patients with acute severe colitis, whenever they have a significant abdominal pain with a tenderness in abdominal examination, really this is a red flag for a toxic megacolon, and you have a low threshold in that time to order an X-ray for them to rule out toxic megacolon. Toxic megacolon is a clinical and radiological diagnosis, meaning having a dilated colon is not enough to diagnose this patient with toxic megacolon. You have to have a clinical or evidence of systemic toxicity. Don't wait for perforation to occur to call the surgery. Call the surgery from day one of diagnosing toxic megacolon. Whenever you have patient with a toxic megacolon, always rule out C. diff and CMV. Never ever perform sorry, I have to correct that here. Never ever perform a colonoscopy or contrast enema for the diagnosis. In those patients, there is a risk of the risk for perforation is very high here. Now, moving to the case number 4. This is the last case.
غيداء.
Sorry, أخذت وقت طويل.
Can we, if possible, if we can move يعني quicker
faster
إذا كان ممكن.
إن شاء الله. هذا ما حطول فيها. Sorry.
طيب.
Okay, so case number 4 was the last case in IBD emergency. A 16 years old boy with ileocolonic Crohn's disease, diagnosed with the Crohn's disease at age of 12, with a phenotype ileocolonic B1 inflammatory at the time of the diagnosis, and started on adalimumab as a primary regimen for a combo therapy, methotrexate and adalimumab. He lost a follow-up for 8 months and missed several injections. He presented today to the emergency department with a 3-month history of intermittent postprandial cramping in the right lower loop with significant weight loss of 5 kg, and over the last 24 hours had symptoms of bilious vomiting, no gases that pass or stool. He has a constipation and severe abdominal distension. On examination, the patient is cachectic, distended abdomen with high-pitched tangling bowel sound with no peritoneal sign. Perianal exam showed skin tag and one healed fistula opening, and high CRP and severely low albumin. So obviously, this patient having symptoms that suggesting of intestinal obstruction due to missing or uncontrolled Crohn's disease. So the acute management of a small bowel obstruction, number 1 is stabilizing the patient. Keep the patient MBO, insert an NGT tube for suctioning, especially if the patient is having a significant vomiting. Start the patient on IV fluid and correct all the electrolyte, put the patient on a strict input-output chart. In the pain control, avoid opioid, because the opioid, it sluggish the motility of the GI tract, and it's going to add more burden on the patient. Type and screen, basic workup, blood gas, light, CRP and albumin, and fecal caloprotectin to assess the disease activity, and start the patient in a broad spectrum of antibiotic like Metro, Cipro, Metro, or Biptazo. Of course, surgical consult, you have to be considered from day 1. Then do for the patient X-ray. When you do the X-ray, you're going to find that is aligned with the symptoms or the clinical picture of the small bowel obstruction, dilated loops, air fluid level with no rectal gas. Of course, you're going to consider CT if the patient is unstable, if you are suspecting perforation. The image that you're going to consider, but not in the acute setting, but later on, is MRE. And really the importance of considering MRE when the patient is after the patient is stabilized and having resolved intestinal obstruction is looking for the reason why this patient having this intestinal obstruction. So looking for structure, how many structure that they have, structure length, location, if there is any evidence of restenotic dilatation, inflammatory, whether the structure is inflammatory or fibrotic or mixed, if there is any evidence of fistulizing disease or penetrating disease like an abscess and fistula. When to consider surgery? When the patient having any signs of peritonitis, free perforation, ischemia, or complete obstruction, or any obstruction that is not resolved by the medical therapy. But for the medical therapy, For patient with a partial obstruction having active inflammation, you consider IV steroid and optimizing the biologic for the patient. Of course, if the patient having a stricture, which is a long-term management, to consider endoscopic dilatation, and I'm going to talk about this a bit in the next slide. Of course, nutritional support is very important. Consider doing TPN. This is not for the acute setting, but I want to highlight this, which is very important thing, that the stricture, it's very important to differentiate whether the stricture is inflammatory or fibrotic, because the management going to be differ. So basically, if it's inflammatory, it's going to show some signs of inflammation in the MRE, like wall thickening, mural hyperenhancement, and hyperintensity and elevation of the fecal calprotectin and CRP, which gonna be reversed by the medical therapy by optimizing the infliximab. In the other hand, the fibrotic one, you're gonna see in the MRE the mural thickening without hyperenhancement, with having a normal calprotectin and CRP. At that time, this patient, he gonna be benefit more with surgical option like endoscopic balloon dilatation or resection or strictureplasty. So just I want to highlight that any patient with fistulizing disease or stricturing disease, which is the B2, they are candidate for upfront medical therapy of anti-TNF immediately without starting with IV steroid. Surgical option for structural disease and pre and post-surgical management is an extensive talk, and it's need a whole session. Maybe later on we can arrange that. I think I got finished. Sorry for being late.
يعطيك ألف عافية دكتورة غيداء، وشكرا جزيلا، مرة رائع واستفدنا كثير، فجزاك الله خير.
دكتور مهند،
الله يعطيك العافية. أما الآن وختامها مسك مع الدكتور محمد أيوب. دكتور محمد if you share your screen. معلش دخرنا عليك دكتور محمد، بس إن شاء
لا
الله
أبد ما عليك.
تفضل.
يعني أول شيء I want to start by saying يعني this is a platform that was made by one human، وما شاء الله شوف قد إيش جمعت ناس مرة كثير يبغوا يتعلموا including us. يعني أنا متأكد 1,000,000% إنه كل واحد مننا تعلم شيء جديد اليوم، ويعني this was not going to be possible من غير جهدك وتعبك اللي أعرف إنه يعني بياخذ من وقتك الشخصي. So thank you very much for doing this دكتور مهند. طيب
شكرا محمد، وكذلك وجودك معنا، ترى هذا إضافة كبيرة، فجزاك الله خير. تفضل دكتور محمد.
طيب everyone can see my screen صح؟ تمام؟
Yes.
Right. So I have two sections that I'm going to talk about. It's all obviously liver because هو أحسن organ في الدنيا. The first one is going to be neonatal acute liver failure. I will dig deep and it's going to be very deep, heavy knowledge, but it's supposed to be also practical. يعني حاتكلم كتير في pathophysiology، بس the point of talking about pathophysiology إنه لما يجيني مريض with neonatal acute liver failure or pediatric acute liver failure, you know exactly what to do. The point of this also is, and this is a situation where automatically أصلاً by the time you diagnose a patient, you're running out of time. يعني you have very few days and your actions really make a big difference in terms of the outcome. So we'll talk about neonatal acute liver failure وبعدين pediatric acute liver failure. This is the outline that I'm going to talk about today. When it comes to NALF, we'll talk about what's different between NALF and PALF, etiology workup, and then management, and a suggested approach that I developed. The definition is the same as pediatric acute liver failure. You have patients that don't have evidence of chronic liver disease, يعني هم جايين لنا for the first time, plus you don't have evidence of thrombocytopenia, you don't have evidence of hypoalbuminemia, and you do have some biochemical evidence of acute liver injury. What that means is that you have some form of elevated liver enzymes. You have coagulopathy that is not corrected by vitamin K, and I have to stress on the dosing of vitamin K. It's 2 milligrams IV for neonates, 5 milligrams IV for infants, 10 milligrams for adolescents. Whether it's INR 1.5 plus encephalopathy or INR more than 2, regardless of encephalopathy. If you see this, if you're not in a transplant center, the first thing you should think about قبل management is call a transplant center. Okay, because that's probably the thing that will help you most in making that patient survive. When it comes to neonatal acute liver failure, we all know as pediatricians, neonatal period ends at 30 days. But the majority of papers included patients that يعني وصلوا إلى 90 to 120 days. The problem with only making it 30 days is that you miss a lot of other causes of acute liver failure that can present a little bit after that. The Saudiya, because of our consanguineous marriages, we do have a lot of autosomal recessive conditions, أكبرها tyrosinemia, and these patients can present with acute liver failure soon after 30 days. And if we limit the definition to 30 days, you risk under-evaluation. You risk under-evaluation, you risk under-diagnosis, you risk death, which is not fun. So from a practical and an inclusive standpoint, the age limit is best set at 90 days. And I can tell you that we're working on a SASLT acute liver failure position paper. The limit that we have set is 90 days so that we can be inclusive to all diagnoses. The first point I want to make is assessment of encephalopathy is very difficult in neonates. حطيت decreased reflexes in red font because بالنسبة لي أنا لو أنا on call وأنا قاعد في البيت and I have a fellow who is في inpatient ward sorry, and they are examining a patient, the first thing that I am very interested to know about is reflexes. The moment you have decreased reflexes, you are automatically grade 3 or more, because grade 1 and 2, which by the way is very mild encephalopathy, they don't usually have decreased reflexes. So once you have decreased reflexes, you really need to think that I have high grade encephalopathy and I'm running out of time. You also have other neurological signs and EEG, which I really stress on getting EEG because it helps you as well in knowing whether you have reversible liver failure or irreversible when you have severe attenuation. The clinical presentation of these patients as a whole is number one, they present between 3 to 18 days of life. This is what they usually present with on history. طبعا المشكلة في history or physical examination findings is that they don't really help you understand the most likely etiology. But this is what you have. Jaundice, وهذه على فكرة كلها لو if you look at the history or physical signs, they are common with other conditions as well. So if you don't do an INR, you will not pick up these kids. So visible jaundice, lethargy, encephalopathy, bleeding, vomiting, and fever, very common symptoms of sepsis. Physical signs are maybe a little bit more specific to liver than historical features. The main etiologies of neonatal acute liver failure يتلخصوا from this slide. James Squires 2022 JPGN paper, it's the one that it's the NASPGHAN position paper for acute liver failure. As the children are younger in age, the more likely that you will have cases of viral hepatitis causing acute liver failure. It's the only time that you will see GALT. You can also have patients with HLH, provided that it's primary HLH. A big portion of it is metabolic, and then mitochondrial and galactosemia. Galactosemia is something that you will also not see in children that are older than 90 days, most likely. I'll talk about them briefly one by one, بس كل واحد منهم في take home message. GALT is the most identifiable cause. طبعا أنا قلت identifiable لأنه في أشياء في 37% of cases are indeterminate. So from the most identifiable ones are GALT. It's one of the causes of neonatal hemochromatosis, but not everyone that has neonatal hemochromatosis has GALT, and I'll explain what that means. The pathophysiology اللي أبغاكم تفهمون فيه. The injury starts before the baby is born. So you have maternal sensitization of fetal hepatocytes, and then mom produces antibodies that is directed against the fetal liver. So guess what? The baby is born with a completely burned out liver. You don't have liver tissue left. So this is why these kids always, they get the history of, لو أخذنا في family history, maternal miscarriages, oligohydramnios, and preterm birth. They usually present very soon after birth. So it's not something to think about if a child is older than 3 months of age. The biggest hallmark حقه is that you have normal ALT and AST, because guess what? You don't have liver tissue left anymore to produce ALT and AST. If they do have it, it's less than 100. They have profound coagulopathy, usually 6.7 and above, and very high AFP, and I'll talk about AFP بعد شوية. Hepatosplenomegaly is rare because, again, you don't have liver tissue left. You may have some ascites. Over time, they do develop jaundice, but they don't have it early on. And they're known to also have very limited glycogen storage, so they will have hypoglycemia and encephalopathy. This is what I'm talking about in terms of GALD versus NH. Please remember that NH is a phenotype. إيش يعني phenotype? Phenotype معناها the way a disease presents. Neonatal hemochromatosis is the phrase that we use لما نشوف عندنا iron deposition خرج برا الليفر أو موجود جوا الليفر. For us to say that this patient has GALD, you have to make sure that you rule out everything else. You have to rule out Dugok. You have to rule out bile acid synthesis defects, congenital HLH, and perinatal infection. Because كل دول يعمل neonatal hemochromatosis. So it's important for me that you know this. We don't say the word GALD unless you have ruled out everything else. Ferritin seems to be the thing that we always do, and it's definitely elevated, but it's not specific to GALD. Because again, ferritin, neonatal hemochromatosis. Any cause of NH will cause an elevated ferritin, but it's almost always above 550, and it can be as high as 1100 or 11,000. Alpha fetoprotein is what helps you. The reason why that is that it's a fetal liver. هو من اسمه alpha fetoprotein. So it tells you that this injury has happened for a very long time, probably intrauterine. زي hepatoblastoma usually uses AFP as a biomarker. It's the same idea. If you have an injury that has happened antenatally, and this will be also relevant when we talk about other diseases, it's usually extremely high. It goes up to 83 to 100,000. The treatment. So the treatment is important for me that you remember you are already running out of time. You refer urgently to liver transplant. Please do not think. Just don't think. Just give IVIG 1 gram per kilo because that's the only way you will stop an antigen antibody deposition. And then if you do confirm that you do have GALD NH, this is when you do double volume exchange, and then you have to repeat your IVIG. In terms of outcome, 75% reach native liver survival compared to only 17%. So شوفوا الفرق قديش كبير. It's 60%. And it's very important that مو بعد ما patient gets discharged خلاص we don't do anything. You have to advise mothers to receive IVIG in future pregnancies to prevent this from happening again. HLH, I have to say أنا من يوم ما رجعت the ones that I've seen are HLH مرة واثنين وثلاثة and a few metabolic ones, much more common than I thought. 10% of NALF cases are due to HLH. The ones that I am talking about are the primary ones. So these are patients that have severe immune dysregulation, which can either be primary or secondary. Primary is usually genetic, and it presents in neonates due to defect in immune cytotoxic T cells. And secondary presents at any age, but most commonly not in neonates, although it can happen. Very important that you remember the HLH 2004 criteria. We do not use the adult criteria. We do not use the MIS criteria. We use the pediatric Paris classification criteria for HLH 2004. You need to have at least 5 of those, and the timing is in 30 days. The hallmarks for HLH, so احنا تكلمنا كل واحد منهم هديكم الهallmark حقه. The hallmark of HLH is that you have serum lactate that is extremely high, and it almost looks like mitochondrial disease. The reason that is because you do have ischemia and tissue injury happening everywhere. The kidneys, the liver, your major organs that need oxygen, they all get injured. And then ATP does not work, فيطلع لك lactate. Ferritin is extremely high, and it may mimic viral infection. And then they do have severe cholestasis, usually reaching above 150 to 200. We always talk about genetics لما نتكلم على cholestasis. This is one of those situations where you really need genetics as soon as you can. Because if this is a primary HLH patient, the only thing that will cure it is bone marrow transplant. And you will never get a patient to bone marrow transplant unless you prove that it's a primary HLH mutation. So you need to do this as fast as possible. Outcomes, 100% mortality rate. This is what has been published in patients with primary HLH by 4 months. You probably already know that we cannot transplant them because you're basically transplanting an end organ damage. We're not curing anyone. So if you transplant these kids, they can develop HLH again. In my experience, they do actually respond to high-dose dexamethasone or etoposide, but you're using this as a bridge to transplant. You're not using it as mainstay. You're doing it so that you can keep them stable, so that they're well enough to go into bone marrow transplant. Viral infection is a big cause of acute liver failure, whether in neonates or adults. In NALF, they present about 7 to 20%. It is almost non-existent in KSA cohorts based on the published studies. These are infections that are acquired transplacentally, and therefore they present very soon after birth. These are the infections that are common to cause NALF. Probably the most common one is HSV. You need to know that this is the most lethal. Mothers can be asymptomatic. الphenotype, if you remember from residency, في عندنا 4 phenotypes مختلفة ال HSV. The ones that typically present in neonatal acute liver failure is either isolated hepatic or disseminated HSV. بمعنى آخر, they may not have a rash to look at وبعدين نقول, oh, this is probably HSV. They will not have that rash. So زي GALD, when you think about NALF and 20% of NALF cases are viral infection, you probably should act, and I'll tell you how to act. Mortality is 90% if untreated. Enterovirus, they can present with cutaneous rash and neck. The ones that develop neck, because of enterovirus, have a very poor prognosis. Adeno causes respiratory symptoms. Parvovirus B19 is common في tables اللي تشوفوها في papers, but we don't actually see it. They don't usually reach يعني neonatal life, unfortunately. HHV6 is also another one. CMV, بس كلمتين عليه. It's not typical that they cause acute liver failure. If they do, you should see signs of symmetric IUGR. It's usually very slow. They have prominent cholestasis أكتر شيء. And from all of these ones that I'm talking about, they are the ones with the favorable prognosis. The hallmarks are really features of acute hepatic necrosis. So you have ALT and AST exceeding 1,000, or probably 1,000 مرة قليل. It's usually much higher than that. They have profound coagulopathy, and their ferritin is extremely high. طيب, the reason why ferritin is extremely high, and this is how I always explain it to fellows and residents, the reason why أصلا إحنا نشوف الليفر في X-ray, لما نسوي abdominal X-ray and you see the liver, it's because the biggest portion of iron that you have in your body is in the liver. طيب, liver, well, iron is radio opaque. So when you have severe necrosis, that ferritin gets spilled from the liver to the outside environment. So because of the severe necrosis that they have very high ferritin. It can be confused with HLH, but I'll tell you about things that will help you differentiate between all of them. Because of the high risk of mortality, every patient with NALF should get IV acyclovir after you do all the blood testing. And you can consider ganciclovir if you have CMV-related features. We usually would consider transplant only in patients that are stable, the ones that have overwhelming infection. We do not. Mitochondrial, another very big portion of neonatal acute liver failure. This is a very big group of patients. It's respiratory chain defects, it's fatty acid oxidation defects, and it's mitochondrial DNA depletion. It's very rare, about 7 to 10% of NALF. We see it here probably more than other countries because of parental consanguinity. Timing is usually after the 2nd week of life, so it's not something that you would typically see in the first 2 weeks. It has a very broad liver phenotype. Not all of them present in acute liver failure. Some of them present with cholestasis. But if they do present with acute liver failure, حتكون عندنا شوية decompensated liver disease picture. بمعنى, you will see splenomegaly, you will see hypoalbuminemia, and you will see some form of cholestasis. Their hallmark feature is you have extrahepatic stuff. So far اللي أنا تكلمت عليهم كلهم تقريبا ما عندهم كتير extrahepatic. This is one where you do have extrahepatic features: brain, heart, muscle, and kidneys. So translation, هنلاقي high-grade encephalopathy, generalized hypertonia. You can sometimes see nystagmus, even brain MRI changes, microcephaly, cardiomyopathy. They do have high anion gap metabolic acidosis. The typical scenario, and they say, أنا ماني فاهم ليش عنده قد كده metabolic acidosis. His heart rate is fine. His blood pressure is fine. I am giving him enough GIR. And it's because ما عندنا أصلا mitochondrial function. So it's out of proportion to the degree of hemodynamic stability. Lactate is very high. If they do develop hypoglycemia, and that's mainly in DNA depletion syndromes like Dugok, it's usually non-ketotic hypoglycemia. AST is higher than ALT because of mitochondrial dysfunction, and we know that AST قاعد في الأماكن اللي فيها very high mitochondria like muscle and even inside the liver. And AFP is very high once again because this is an injury that happens even antenatally. The workup لازم يبغى له شوية extensive workup لأنه this is a patient that you probably already know كلكم. We cannot transplant them. ما عدا اللي عندهم isolated liver disease. So you have to prove من غير genetics, especially in the early phase لما نشوفهم, that we have mitochondrial hepatopathy. You have to do MRI with MRS, CSF lactate, echo, and CPK. You should, as much as you can, do a muscle or a liver biopsy. Ask about mitochondrial copy number. And then obviously you need whole genome sequencing. Very important that you remember to ask for mitochondrial DNA sequencing, because that's a whole different gene. Management, unfortunately, is supportive. It's optimizing nutrition, avoiding prolonged fasting, IV dextrose, and just avoid medications that can cause mitochondrial dysfunction. As I mentioned, transplant is controversial because some of them may have progressive irreversible neurological impairment post-LT. A very common example is Pol G or Dugok, فmay be considered only an isolated hepatic disease. بعدين نيجي للأشياء اللي بسببها we did the guideline to 90 days. Galactosemia is very important for you to remember, بالذات نحن عايشين في السعودية. It's the most common identifiable cause of NALF in Saudi Arabia, so 17%, more common for northern regions of the country, and this is already published. And it has been part of the newborn screen since 2005, but it's not always implemented. The pathophysiology بكل بساطة, you have an enzyme defect, ما تقدر توصل galactose ولactose لجلوكوز. اللي هيحصل له accumulation is G1P, and G1P when it accumulates, it injures every organ that it stays in. So RBCs, liver, kidney, brain, and cornea. They present very early, especially if they are taking lactose or glucose. Most commonly, most of them, they present within the first 30 days. The hallmarks are your bilirubin is sky high. ليش؟ لأنه عندك hemolysis وعندك liver injury. You have both. So you have indirect and direct. You do have very mild enzyme elevation. AST is typically higher than ALT because of the hemolysis. Mild coagulopathy, very characteristically, when they eat, they develop, not seizures, but they develop hypoglycemia. Because كل مرة they're going to drink, they cannot move down to glucose or lactose, so they develop seizures. Okay, and E. coli sepsis happens in 10%, and that's because G1P, it alters bactericidal activity. Workup is very simple and straightforward, and is one of the things that you really have to do very quickly. Screen with urine-reducing substance. You confirm with low RBC GALT, which, by the way, doesn't take time, and genetic testing is usually not necessary. If you don't treat it, death can happen within the first 6 weeks. So at your earliest suspicion, you should eliminate galactose or lactose, and that unfortunately includes breast milk. IV antibiotics, and then we do transplant them, but we transplant the ones without that are not responsive to diet changes without sepsis. Tyrosinemia, this is the second most common cause of acute liver failure in neonates. 12% يعني, has been part of the newborn screen since 2020, but the choice of testing is serum tyrosine, which is not sensitive. Serum tyrosine can be elevated from a lot of different things, so it's not sensitive. Unfortunately, it doesn't pick up. ومعظم اللي it picks up false positives. The pathophysiology based on the algorithm that you see on the right, or the figure, it's deficiency of an enzyme called FAH, and that causes accumulation of fumarate acetate in liver and kidney. عشان كده اسمه الثاني is hepatorenal tyrosinemia. ويسوي Fanconi syndrome. Timing is very important. So this does not present in the first 3 weeks of life. It happens right after. Because you need some time for accumulation. It's not as quick as galactosemia. Median age is about 32 days. Your best test is just a succinyl acetone, either serum or urine. You can get it, by the way, for plasma amino acid profile or urine organic acid profile. The hallmark is that you have mild liver injury. So ما حقول لكم إنه هو مرة شبه GALT, بس عشان نبدأ نشوف features. You have يعني خلاص الليفر يعني معظم الناس they don't present with fulminant acute liver failure. They do have mild liver injury because أنت بدأت تشوفه when the liver is يعني coming at a stage where where the liver is coming at a stage where you're developing cirrhosis. So ALT and AST are quite low compared to the coagulopathy. They have very high AFP. Looks exactly like GALD أحيانا, but the timing is different. You might find nodular liver contour on imaging, and then they develop RTA. The management, if you detect them early, you start nitazoxanide, and you start the appropriate formula, they do improve. The ones that don't get treated develop HCC. A common question that we get asked all the time, مين اللي ينحط على نيتازينون ومين اللي ينحط على transplant list. If you have a patient who is in liver failure and you feel like your emergency transplant is necessary, just don't delay, just go. If you feel like you have a contraindication for transplant, this is when you can consider NTBC treatment, and then elective transplantation when you start seeing nodules. Patients اللي they get nitazoxanone على طول هم the ones that are detected asymptomatic in the newborn period. And then if they do develop nodules over time, those are the ones that you transplant. Urea cycle بس كلمتين. You have two ones that can cause acute liver failure in neonates, OTC, which most commonly comes in boys because it's X-linked recessive, and ASS, which is autosomal recessive. القاسم المشترك بينهم, those are part of the urea cycle that only happen in the liver. So enzyme deficiency leads to defective ammonia detoxification, and then your protein synthesis doesn't work, and then you develop acute liver failure, usually in the first 3 months, but it can happen at any time. الأشياء المهمة that differentiated between other causes, you do have high-grade encephalopathy with ammonia. You do have hyperventilation because of the high ammonia, and then that hyperventilation causes respiratory alkalosis. Ammonia is extremely high. يعني احنا بنتكلم minimum 150. Most of them are above 500, disproportionate to how coagulopathic they are. You can detect it with plasma amino acids or genetics. Urine orotic acid is what we use for OTC. ASS deficiency, you'll find elevated citrulline. Urea cycle is one of those situations where you have a medical emergency. You need ammonia scavengers because you need to protect the brain with IV benzoate and arginine. Indications for dialysis is usually ammonia more than 300, and keep their GIR quite high because you need to, يعني الفكرة العامة, we just need them to stop breaking protein. فأنت لازم تدي لهم alternative sources of energy. So that's dextrose and lipids. Transplant is considered in children without severe encephalopathy, especially OTC, and a lot of us are even starting to think that it's the standard of care for OTC. It provides a metabolic cure, eliminates dietary restriction. Indeterminate, this is the term we use when no etiology is identified, provided that you have done everything. You have undergone complete and extensive workup, including biopsy and genetics. Unfortunately, it is the most common, يعني, subcategory of NALF, 38%. But it's possible إنه الأرقام هذه are quite high because a lot of patients either got transplanted or died prior to completion. It can happen at any time. You should know that this is going to start changing its name to T-cell mediated hepatitis because most of the patients that have indeterminate NALF, they found that they have CD8 T-cell infiltration into the liver and causes hepatic necrosis. The biopsy may show that, very high levels of inflammation. These are the immunohistochemical stains that are typically positive. They may behave like HLH, but they're not HLH. And then the outcomes, unfortunately, these are the ones that really need a transplant very quickly because what are you going to treat? There's nothing to treat. So without transplant, mortality is 70%. IV pulse steroid is considered in them, and plasmapheresis as well as ATG. يعني pulse steroid is a must. If you cannot see any etiology قدامك, you need to think about pulse steroid. All patients with NALF, this is my approach. دحين احنا خلاص بدأنا نخلص NALF. All patients with, in my opinion, should receive the following situations. زي ما دكتور مهند قال لكم, إذا الواحد سوى to detect one foreign body, please just send everything. Send everything that you have. Because انت يعني NALF situations, you're just picking up clues. يعني genetics, we all know that they take minimum 3 weeks to 6 weeks. هذا في الأماكن اللي فيها genetic testing. So a lot of the work that you're going to do is pure clinical. So this is the workup that all patients need to get. That includes workup for all conditions. And then what I was able to do for you, لو واحد منكم غالبا معظمكم يعرفوا Peter Whittington's paper for neonatal acute liver failure. So I was able to do one that is similar to it, but it includes more information based on literature. I've highlighted the ones in red so that you know exactly how to pick up on those cases. So timing, زي ما تكلمنا فيها already, the one that is different is tyrosinemia يجي متأخر. Probably everything else comes earlier. IUGR, you'll see that more commonly in GALD and NH, as well as viral infection and mitochondrial. Consanguinity is based on autosomal recessive conditions. extrahepatic features. أنا برأيي الشخصي this is the one thing that helps you أكتر من أي شيء تاني. GALD يكون عندهم oligohydramnios like we discussed. HLH you have bone marrow involvement. Tyrosinemia يكون عندهم hypophosphatemia, hypoglycemia, because they basically have proximal RTA. They sometimes get lung and liver nodules. Viral infection, it depends on the underlying cause. Mitochondrial, you'll see a lot of neuromuscular changes in them. Galactosemia, well, if it's not treated, you will develop hemolysis and E. coli sepsis. Urea cycle, قلنا hyperventilation. Abdominal imaging is helpful for GALD and NH, tyrosinemia, because they show you ascites, nodular liver. Mitochondrial is by far the only one that presents with hepatosplenomegaly from the. And then in terms of هذه اللابز اللي كلنا نطلبها وما نسوي فيها أحيانا, the ones that develop profound coagulopathy or galdoviral infection. Glucose, even though we always think of it as the end stage thing that happens in acute liver failure, بس يعني think about it أكتر about mitochondrial disease وgalactosemia when you see it happening very, very quickly. Ammonia is highest in urea cycle. Acidosis is worst in mitochondrial disease. Think about galactosemia in severely ectatic patients. ALT is أرهب شيء. Very mild increase in GALD, and then it becomes normal completely. أنا بتكلم 15, 20, and an INR of 9. Think about GALD. And HLH plus mitochondrial plus galactosemia with varying numbers of enzymes. Obviously, I think when AST is higher than ALT. AFP is highest in tyrosinemia and GALD. بس لو تفتكروا قلت لكم there's a difference in time. GALD happens in the first 2 weeks. Tyrosinemia happens after, at 21 days and above. And then ferritin is your best friend. Doesn't help you with viral infection. It just confirms that you have necrosis. Okay? Few different approaches to how people do it. This is one that has been established by Chicago, Lurie Children's Hospital. They start with acyclovir, and I 100% agree with that. And then they look at the enzymes. If your enzymes are low, you consider that this is GALD, you give IVIG, and then you do your standard workup, including focus شوية على GALD. If you find that you have NH and you've ruled out everything else, then you start your double volume exchange and you repeat your IVIG. The opposite end of the spectrum is that you have high elevation in liver enzymes. This is when you start thinking of things other than GALD. So you have to look for viral HLH and genetic etiologies. And then based on what you find, if you have disturbances, you think about mitochondrial, you have an extremely high ferritin, you think about HLH or fulminant viral hepatitis. If you're curious to know ايش بيصير في السعودية, this is the only published paper that we have so far. I'm pretty sure there's lots coming up. 42 patients, the majority, if you look at them, are metabolic, galactosemia, tyrosinemia, and mitochondrial. The one important thing you also take from this is that the mortality rate is 55%. I'm talking about the mortality rate with transplant being available, because if you look at this graph, في alive, but the alive was post-transplant. So if you take into consideration that you do not have transplant as an option, if you do a little bit of math, هيطلع 65%. So it's one of those cases where you just have to go very quickly and you have to call your best friends اللي هم transplant surgeons. The general management is transferring to liver transplant center, central IV access. Please give antibiotics. مو لازم culture. IV acyclovir. Give sugar. Target GIR is about 8. Please use D5 half normal saline because هم شعرة and they get fluid overloaded. So half normal saline, lactose-free formula until you figure out if it's galactosemia or not. Think about IVIG very quickly, if you can, and then CRRT if you have hyperammonemia. This is the first part of my talk. PALF هتكلم فيه 10 دقائق بالكثير. So it's the same as NALF in terms of definition, but things are a little bit different. The first thing is this is a common scenario to all of us, general pediatricians, pediatric GI, and a liver transplant center. Please, anyone that comes with biochemical evidence of liver injury, inshallah لو في العيادة and they look beautiful, please check coagulation. You will be surprised about how many patients you will pick up with acute liver failure جايين العيادة. They don't look like they have it, but they do have it. So if you do have an INR that is quite elevated, you suspect liver failure, you give vitamin K, you repeat it. If it's high, please refer to a tertiary level center. Okay? The battle that we always have is when patients come with acute liver failure, we don't know if they will recover without transplant or they will unfortunately die. What we do with the liver transplant is that we interrupt the natural history of what they will go for. Unfortunately, there's no way that we can figure this out. Our job is to basically to support them and try and improve survival as much as we can, even if it means that they might have recovered and we eventually send them for transplant. In PALF, اللي هم الأطفال اللي above 90 days, your etiology is different. You start seeing acetaminophen overdose, autoimmune diseases, viral, but the viral ones are different. Now we start seeing Wilson's and other metabolic disorders. HLH is still part of it, but it's usually secondary HLH. History and physical exam is key because you also have to choose wisely. Think about your infections, recent travel. When it comes to toxic liver injury, think about herbal substances, herbal supplements. You'll be surprised how many you will find. And then when it comes to autoimmune, think about it when you see a mother with vitiligo, very common scenario. Patients that have very high autoimmune load, metabolic, you automatically think about if you do have some form of consanguinity. Examination helps you in just narrowing down the diagnosis, but they also tell you whether this is acute on chronic or just acute. When you have splenomegaly and ascites, you should think that this is acute on chronic, which is a whole different story with a very different mortality rate. The workup is not the same. طيب. So in children that are less than 3 months اللي هم الألف اللي تكلمنا عليهم and 3 months and above, the workup is not the same. الأشياء القواسم المشتركة, you need to also do HSV, serum amino acids, ferritin because of, but obviously it's different في الكبار. احنا بنسوي ferritin عشان HLH. Lactate to pyruvate because mitochondrial can present at any time. Plasma acylcarnitines for fatty acid oxidation defects. Tyrosinemia you no longer need to do. Enterovirus can happen at any time, so you have to do it. Acetaminophen is usually in older children. And then الليستة اللي احنا متعودين عليها. Hepatitis A, B, C, CMV, EBV هدول كلهم in older children. And then this is when we also think about autoantibodies and Wilson's disease. Running down the list, most of them are still there, with the exception of galactosemia or tyrosinemia. You don't have to look for them. Your priorities as a fellow plus consultants, حتى لو احنا ما بنشتغل في liver transplant center, is to stabilize and then stabilize a little bit more and then transfer to a liver transplant center and then stabilize again pending transfer. Really is a في واحد شيء مهم, protecting the as the moment your brain gets injured because of whatever liver causing the liver failure, this is when things become very muddy and then you don't really can transplant these kids. So that's why we always try our best to identify the etiology and treat as early as we can. And then it's also our job to find contraindications to transplant. This is the general management for PALF. بصراحة, I don't think we have enough time to go through it. But you can take a screenshot or حتى Dr. Muhanad can send it to you. But it's basically ICU high-level care. It's protecting the brain. It's making sure that they are on pressors. Ventilation is needed, restricting fluids, high GIR. One thing important, the sodium thing. Please keep the sodium high, especially in patients that are already encephalopathic, and that's because you want to avoid hepatic encephalopathy and cerebral swelling. Keep your albumin above 25, please. GI bleeding is a real risk, even though دايما نقول إنه they don't have coagulopathy, they're not going to bleed, but they can develop a peptic ulcer. Because of the stress. Infection, IV antibiotics من غير ما نفكر, please. Coagulopathy with vitamin K 3 days, and then avoid FFP as much as you can, unless you know that you're undergoing a procedure. Question that we always ask ourselves is why do we do more? يعني أنا already وريتكم التable هذا, and we still do more. And the reason for that is that the mortality rate is quite high. So far, we don't have anything to predict whether they can live or not. And sometimes patients are too sick or too unstable to transplant. If you've tried calling a transplant center and you told them about the patient that you have, sometimes they will tell you it's very clear that they're too unstable to get transplanted or they're too sick. Because the contraindications for transplant in acute liver failure is if you have someone with high ventilator requirement, high dose vasoactive agents, or evidence of irreversible neurological injury. So those patients develop multi-organ failure and you cannot transplant them. Ones that get uncontrolled sepsis, unfortunately, you can't. and then mitochondrial or primary HLH. My point of doing this is I want to convince you somehow that you can change this into a patient that has no contraindication, and that's by doing extracorporeal liver support. Okay, هذه ما هي موجودة in pediatric guidelines, but it will become standard of care. We do it in patients that are refractory to medical therapy, and we need to stabilize them. The way we do it is that we need to remove toxins. يعني احنا دحين عندنا واحد بأكيوت liver failure. يا إما جاله acute liver failure because of a condition where accumulation اللي صار is toxic to the liver, or بعد ما صار عندنا acute liver failure بغض النظر إيش السبب صار عندنا cytokine storm. Okay, so the things that are toxin driven in the body in an acute liver failure, عندنا water soluble toxins, those are ammonia, urea, lactate, and fluids, and potassium and phosphate. And then you have protein bound toxins. Those are cytokines, adhesion molecules. I'll talk about DAMPs in a bit, autoantibodies, copper for Wilson's, bilirubin or bile acids, as well as aromatic amino acids. How do we remove water soluble toxins? It's CVVH or CRRT. This is a courtesy of Dr. Razan Badr, and I thank her very much for sending me these information. In PALF, it's patients with high levels of encephalopathy, hyperammonemia, and kidney dysfunction. It really works. You just have to be high dose, and you have to do it as fast as possible, and it really does help. In patients that we don't have issues with water-soluble toxins, we think about plasmapheresis. This is just a paper that I'll show you very quickly. This is an adult-based study that shows you that the earlier you choose to use CRRT, the lower your ammonia, and the lower your chances of death. So it does help in a small minority of patients. Plasmapheresis is the other thought that we always have. Very simply, الجراف الحلو ده, when you have hepatocyte death from whatever reason, you develop something called DAMPs. These are basically vasoactive cytokines, and they just go crazy. They cause macrophage activation, and then they start causing tissue damage and inflammation everywhere. We're talking about SIRS response. We're talking about even secondary HLH, and they can start causing multi-organ dysfunction. So plasmapheresis, you're basically removing these things, and it's a form of immunomodulation. We use it in patients with refractory coagulopathy, evidence of multi-organ failure, Wilson's, and immune-mediated PALF. We use it as an adjunct to CRRT, and this is particularly relevant للأماكن اللي ما عندها liver transplant. يعني we are waiting to transfer someone to a liver transplant center. What can you do after كل الليستة اللي اتكلمت فيها to stabilize the patient a little bit more? It's CRRT plus minus plasmapheresis. And then we usually do them for 3 days, and then we see what happens. Very small study on high volume paracentesis significantly improves transplant-free survival, especially in patients that did not need a transplant. Okay? So this is the last slide that I have. So to conclude, please, GI fellows, GI residents, whether you're dealing with MALF or PALF, your job is to stabilize and transfer. Identifying the etiology is like solving a 10,000-piece puzzle. Use all the clues you learned, whether اليوم or في أي يوم قبل كده, to narrow your differential diagnosis. Please take history again, examine again, and reevaluate. Look for indications for transplant, contraindications for transplant. All of these things are things that will help you in figuring out what's going on. Please don't hesitate to perform the necessary workup. I've heard it a million times. دكتور السامبل مرة كبيرة. البيشنت already الهيموجلوبين حقه 9. يعني, you want to save a life? We have to do everything. If the hemoglobin drops to 5 because of the big blood sample that I got, I'll give him a blood transfusion. بس يعني في النهاية benefit versus risk. Empiric treatment is key, especially in neonatal acute liver failure. Please monitor and manage complications, and think early as much as you can about CRRT and plasmapheresis as a bridge. We're never using them as standard of care, but we're using it as a bridge to transplant, especially in patients that are too sick to transplant or patients that are too sick to transfer. يعطيكم ألف عافية, and I've come to the end of my talk.
شكرا دكتور محمد، يعطيك العافية. يعني مرة شيء رائع واستفدنا صراحة كثير، فجزاك الله خير، يعطيك ألف عافية. شكرا لذلك دكتورة غيداء. أنا أشكركم فعلا لأنه هذا تطوع منكم، وهذا في الويكند وأخذنا من وقتكم كثير، فيعطيكم ألف عافية. أتمنى كانت محاضرات مفيدة و to the point، وأعتقد أنها كلها clinical oriented، وأعتقد أنها إن شاء الله بإذن الله تكون مفيدة لكم للإكزام. فبإذن الله إن شاء الله يعني تكونوا استمتعتوا. أنا أعتقد ما حنفتح مجال للأسئلة لأنه تأخرنا، لكن بعدين إذا في أي أحد عنده سؤال he can ask in the group الواتساب group and we are more than إن شاء الله welcome to answer you. فنراكم إن شاء الله في محاضرات ثانية، ونراكم على خير، تصبحون على خير إن شاء الله.
يعطيكم ألف عافية. Thank you very much.
شكرا، يعطيكم العافية.